Assalamu alaikum. Welcome all to the urology session at the Shaukat Khanum Symposium. Sorry, we are running a bit late. Professor Shehzad, who's supposed to share, unfortunately has been caught up in traffic. So I shall be officiating in his place. We have an exciting program for today. And to begin the proceedings, Dr. Syed Hussain, very kindly, Professor of Medical Oncology at Sheffield University in the United Kingdom, has consented to grace the occasion, and he shall be talking on updates in bladder cancer. So could I invite you, Professor?
Thank you. Assalamu alaikum. Thank you very much, Professor Kuramir. Thank you so much to the organizing committee. It's always a pleasure and privilege to be at Shaukat Khanum Symposium. And today we'll be talking about some of the updates in bladder cancer and how things have changed over the last few years. And over the last year as well, there's been significant change in the treatment of advanced bladder cancer. And we'll try to look through that and looking at how the health economics and the cost of the drugs and all that will have an effect on these treatments as well. These are my disclosures. So in terms of, we know that platinum-based chemotherapy has been a mainstay of treatment for bladder cancer, but the outcome and survival has been very limited, and 9 to 12 months median survival with cisplatin ineligible patients. And for platinum-eligible patients, it has been in the range of about 15 to 18 months. And that, unfortunately, had not changed over many decades. Then came the maintenance avelumab trial, Javelin 100, which refined the standard of care. And with immune checkpoint maintenance treatment with avelumab, that changed the survival outcome significantly. More recently, EV302 trial, which was looking at pembrolizumab with the enfortumab vedotin, and the checkmate study looked at the role of addition of nivolumab with gemcitabine and cisplatinum, followed by nivolumab maintenance treatment. In terms of Javelin bladder trial, always look at the number of patients in different sort of settings when you look at, and if you look at in Pakistan, when we can give platinum-based chemotherapy to patients, it's a cheap and effective drug, which does respond patients respond well to chemotherapy. And I think when we talk about in UK as well, I've been to NICE multiple times with nivolumab, avelumab, atezolizumab, and always the question is health economics and the cost effectiveness of the drug. We are going for dafitinib next month, and we're going for enfortumab vedotin in March. But I think with the cost of these drugs, it plays a big role in UK, in the National Health Service as well. And I think every country has to really look at, because health economics is important, the cost of the drug is important, and cost effectiveness does play a key role in how you select your patients. But I think if you're going for maintenance avelumab, the important thing to remember, this is from a randomized trial, which showed almost 70 to 80% of patients will be at least having complete response, partial response, or a stable disease, which will make them eligible for maintenance avelumab treatment. And the real world data is showing the same, that actually in real world setting, we are seeing improvement in outcomes for these cases. So one thing that you always learn is that, for example, in clinical trial, we think it's a much more selected patient population. There is a selection bias in clinical trials. But with the passage of time, you learn how to deal with the toxicity of the drug, and that often helps to improve the exposure of the drug, which improves the outcome. So with avelumab, there's quite a significant amount of real-world data that we'll talk about. In terms of the median overall survival from the start of randomization is now 23.8 months. And in the post-hoc analysis, if you look at it from the start of chemotherapy, first-line palliative chemotherapy, the median survival is 29.7 months. And that is quite an important figure, because just a few years ago, we really used to struggle our patients going through 12 months. I used to call it the anniversary visit for patients with metastatic bladder cancer when they come and see us a year after their diagnosis. And that was so true till a few years ago, where things have started to change. The clinics are running till 7, 8 o'clock at night. And the reason is that these patients are living longer and doing much better, and outcomes are improving. When you look at the treatment options, you look at overall survival, you look at progression-free survival, response rates, treatment-related adverse events, and patient-reported outcomes and quality of life. But disease characteristics are important as well, looking at higher or lower tumor burden, visceral or non-visceral mets. This is important for the patients as well, because when you're talking to them about prognosis, these are important criteria to look at, whether there's a liver mets or bone mets, in terms of Bellman criteria, what are the risk stratification? That helps you to talk and set the stage for the patients and help them make informed choices. The key thing as clinicians and as multidisciplinary team, we always need to do is to keep the patient as the central figure in our discussions, because the quality of life is important and patients will have different priorities and preferences as well. And it is so important to focus on all that. And then patient characteristics, fit or frail, clinically relevant comorbidities, and eligible or ineligible for platinum-based chemotherapy, as the outcomes will be different. And then comes patient or physician preferences. We often look at overall survival as the main gold standard. Patient may look at the quality of life. A patient who works with instruments and things like that may think about neuropathy as one of the major factors. They don't want pins and needles in hands and feet. So different things will make a patient to make different choices. In terms of the efficacy and safety with the first-line treatment, what is key here is that with Javelin 100, you've got quite a long-term follow-up data on these patients, because in the forest plot, if you look at in terms of the different patient characteristics, whether they had cisplatin, or carboplatin, if they're cisplatin ineligible, whether they're elderly, even above 80-year-old, got benefit from maintenance avelumab. And I mention that because it is so important not to judge your patient based on age. We have got 84-year-old patient who have done extremely well, and we have got with platinum-based chemotherapy and could not carry on. So it should never be based on age, which I will show you that actually median survival in over 80 was significantly more if they had chemotherapy followed by maintenance avelumab compared to standard of care treatment within the trial. So all that is favoring all those different subgroup population. When you look at the forest plot, is favoring maintenance avelumab. And this is the exploratory post hoc analysis. If you look at this as platinum gemcitabine, the median survival is 31 months versus 23 months. And if you look at the carboplatin, 25.8 months versus 17 months. It is quite important slide, because when you look at the control arm of 23 months, this is quite interesting, because in cisplatinum eligible patient group, you're getting into 33 months, considering the new paradigm of enfortumab vedotin pembrolizumab of 32 months. In cisplatin eligible, you're getting that amount as well in terms of patients from starting of their maintenance treatments. Similarly, if you look at the age subgroups, 65 to 75, 28 months versus 17 months, above 75, 24 months versus 13 months, and above 80 years, 24.9 months versus 10 months, with a very significant hazard ratio. So one thing which I always say is that do not deny our patients just because they are 75 or above or 80 or above. Yes, do review them carefully, look at their fitness. And one thing which as a multidisciplinary team we should do is to make sure that patients come through our doors and at least see us. Unfortunately, one of the easiest box to tick in the MDT is the box of palliative care, where people say, oh, the patient is 81, he's got this comorbidity, he had a cardiac event, let's just put him to palliative care. And you find out that cardiac event was actually 10 years ago. So you need champions for the patient who can actually fight for the cause of the patient, that at least they should come through the door of our multidisciplinary teams and look through them, because the survival is not limited to age. It is really based on how fit the patient is and in terms of their outcomes. And we need to try and get more of these treatment options to our patients in Pakistan as well. And that's where I always say about compassionate gain of these drugs for patients. Again, just talking to Jamshed about young 38-year-old patient, how we can get these drugs for those patients is really key. And working with industries and others will be useful to try and get those drugs at times. What is important here is that there was an Asian subpopulation as well. 20% of patients were Asian. Remember, many of the trials we talk about, almost 95% are Caucasian patient population. And it is so important to look at the toxicity and efficacy in patients who are Asian. So these are the patients from Japan, India, South Korea, Malaysia. And again, about 120, sort of half, about 20% of the patients were actually from that group. So it's quite a good big number in those terms, in terms of having these sort of, what was key here is that within that subgroup as well, they're benefiting from the use of maintenance avelumab in terms of overall survival, and progression-free survival as well triples, 1.9 months versus 5.6 months. So significant improvement in Asian patient population as well overall was seen, which is important because they are likely to be more closer to Pakistani patient population. And I think we should always get that data from our set, whether it's few patients, but it can make ripples when you start to work with different colleagues across different centers and sites to bring that forward. Javelin Bladder 100 also showed that actually within the variant histology, there is an impact as well. So I gave a talk at ESMO on variant histology in bladder cancer, and they do very poorly. They have a very dismal outcome. But patients with urothelial cancer with squamous differentiation or glandular differentiation or variant differentiation, the survival was 19 months versus 14 months in the control arm, which was chemotherapy followed by best supportive care or standard of care treatment, which will be second line paclitaxel and things. So in terms of the first line maintenance treatment, the key is that in terms of long-term toxicity, long-term efficacy, once you've given these patients for a year or 2 years of avelumab, what happens to their toxicity levels? There was no new safety signals that were coming out with those. And what was really important was time without toxicity or symptoms of disease progression. And that is so important because you're almost doubling the time without symptoms or time without disease progression by using maintenance avelumab. So I think it's a really important treatment option that we have got, which is available in most parts of the world now. And I think it's important to try and get more for our cases in Pakistan as well. In the real world data, you can see that from the Javelin 100, 5.5 months. In real world data, it's not much different. And in some cases, it is better. As I said, we learn how to deal with these patients and how to deal with the toxicity and try and improve the exposure of the treatment. Similarly, in terms of the 12 months overall survival is very, very favorable compared to what we saw in Javelin 100 trial. In terms of overall survival from the start of Javelin, 23.8 months, 21 months, 23, 24, 26 months in real world data. Similarly, overall survival from the start of chemotherapy is moving into 29 months, 26, 30, and 30.8 months. So in terms of the multiple real world studies, it is telling us that actually these patients are living now up to 2 years and 2.5 years, which is a big positive change in metastatic bladder cancer. If you sequence the treatment, which is key, we have got enfortumab vedotin. You can use it after the use of maintenance avelumab or second line IO. You can see that both in the Evidence study, which is a French study, and the Eucharis study, Eurocase study, which is the Japanese study, both showed a median survival of 40 months in the subgroup of patients who received enfortumab vedotin after the use of chemotherapy followed by avelumab maintenance treatment. So these are really important figures, and this is really exciting to see. We have a number of patients who have had maintenance avelumab or had second-line atezolizumab who had 2 years of treatment, and they are with us 4 or 5 years down the line. And they ask me the question, have I been cured of my metastatic bladder cancer, when I gave them a figure of 12 months, 18 months median survival. So platinum-based chemotherapy remained, but Javelin Bladder 100 has shown and changed the outcome and has changed the landscape. Then EV302 and the Checkmate 901 comes into play. Checkmate looks at Gem plus Cis plus nivolumab. So what is the difference here? I think the key thing is that you're getting, rather than maintenance avelumab in Javelin 100, you're looking at maintenance nivolumab. What is additional is this additional 4 cycles of nivolumab that you're using with Gem Cis. What is the other difference is that this is all cisplatinum eligible patient, which almost sort of takes away about 40 to 50% of patients who are cisplatinum ineligible. So that is a big difference. You are very selected patient population, cisplatinum eligible, giving them few extra cycles of nivolumab to see whether it improves the outcome. It's a positive trial, was presented at ESMO. Again, if you look at the overall response rates are looking good in terms of the complete responses and partial responses. But if you look at the total number of progressive disease, because the key thing, what is additional, is this additional nivolumab that you're giving with chemotherapy. But that additional nivolumab does not change progressive disease significantly, 9.5% versus 12.8% in the standard of care arm. So it's not that will make a difference. So additional nivolumab is not making that much difference. But in terms of overall survival, 18.9 months versus 21.7 months, and progression-free survival, 7.6 months versus 7.9 months. So limited benefit, but again, a positive trial by design that it was looking at overall survival. It meets its primary endpoint, hazard ratio 0.78 and p-value 0.02. So overall benefit was seen after 6 months more. And the difference is that in Javelin, patients who are not progressing on platinum-based chemotherapy is more than 80% of patients who will be eligible for maintenance avelumab. But if you look at the Checkmate 901, almost half of the patient will be cisplatinum eligible, half will not be eligible. So you're looking at those 50% of cases. So I don't think that survival is significantly much more than what we see with Javelin or with EV. EV plus Pembro, really exciting treatment option, but often we should not just take it as a new kid on the block and try and use it because we need to look at toxicity profile. We need to look at the efficacy very carefully before we think that could be the next standard of care. The trial data is significantly positive. We saw looking at EV Pembro plus, this is relevant for all patients from the start of treatment. So it is not looking at patients who progress on treatment. So it does look at those patients who are presenting to us with advanced bladder cancer, which is inoperable. Really exciting figures, 16 months versus 31.5 months. Really big news to see bladder cancer coming into 31 months and doubling of progression-free survival as well from 6 months to 12 months. These are really important figures, and that made a big headway, big sort of a media coverage and all that. But I think cost is important. In UK, it costs about £20,000 per cycle. In USA, it's $36,000 per cycle. And we cannot really disengage health economics from it. Even North Americans feel like that insurance will pay for it, but who will pay for that insurance in the long run? So there are lots of debates around it. And I think I always say that always look on the ground reality, what you can afford for your patients. Could we go from GemCis to maintenance immunotherapy, avelumab or something? Do we have second line atezolizumab that we can get? But look for those options for our patients and work with colleagues and sort of commercial partners and the hospitals to try and get for them. But EV Pembro is exciting and important data, doubling the survival, but this is for all patients. Overall response rate is quite high in that sense, looking at the response rate. So there is a chemotherapy element too, because it has got Nectin-4 conjugate antibody, what enfortumab vedotin is. And overall, we look at the patient-reported outcomes. There's no significant change. Remember, it is being compared against chemotherapy. And we know chemotherapy causes toxicity, causes neuropathy and things. But enfortumab vedotin as conjugate antibody has a different class of toxicities. And it is important to remember that. When we use these drugs, they can cause significant toxicities, and we need to be cautiously looking at it. Treatment-related adverse events were there, especially the neuropathy, and grade 3 neuropathy is quite significant. Similarly, pruritus. These are quite common. Maculopapular rash is very different to the rash that you get from immune checkpoint inhibitors. So you need a very friendly dermatologist, as you wanted for immune checkpoint. You wanted a gastroenterologist, you wanted a hepatologist, you wanted a colorectal team, just to make sure, and endocrinologist to talk about. Similarly, with these, we do need those plus additional cardiology and dermatology help as well. So severe skin reactions, if we look at the significant reactions, which are grade 3, 68, 15.5% skin reactions, and 6.8% peripheral neuropathy. And these are quite big figures when you look at the grade 3 toxicities in that sense. And as I said, maculopapular rash, if you say 39%, that is 53 out of 137 who had some toxicity, they had residual grade 2 or more toxicity still there. And the same with neuropathy. If you get neuropathy, 50% had residual grade 2 or more neuropathy. It is so important to be looking at those very carefully, because these things will have a lasting impact on patients' quality of life. Somebody who gets significant neuropathy and difficulties in buttoning their shirts or having difficulty in putting their shoes on and things like that. So neuropathies are, and that's why whenever we use these drugs, we owe it to our patients to carefully monitor them, very carefully review them regularly, and monitoring their toxicities as well. How it works is that with conjugate antibody, they've got Nectin-4, and once enfortumab enters, it causes the cells to die. So this is not a chemo-free regimen. And that we know, that's why it is important to look at what is driving the response. And I think Nectin-4 amplification has been proposed as, because what we see is that 26% of Nectin-4 positive in terms of amplification. Tom Piles presented the data last month at ESMO on the immunohistochemistry, and almost 80% have IHC Nectin-4. But I think IHC doesn't pick the patient, but Nectin-4 amplification may pick the patient, especially when you get for these high-cost drugs. Often NICE throws these questions to us. Can you select a subgroup? Because the cost is so high that we can try and sort of rationalize the use of it. Like we get nivolumab, NICE only funded it for PDL positive patients, which is 40% of them, where the hazard ratio was 0.55 compared to hazard ratio of 0.7 for all patients. So NICE always throws these things, and it is useful thing, I think, to make sure that regulatory agencies look at that to try and make it more cost effective. There was a regimen, there was sort of a Evita, which was Enrique Grande's ideas, looking at performance status more than 2, hemoglobin A1C, because hyperglycemia is one of the major factors with enfortumab vedotin as well. looking at low GFR, any retinal or corneal changes, or grade 2 or more peripheral sort of sensory or motor neuropathy as one of the key criteria in which you should not consider patients for enfortumab. But this is a proposal. These need to be investigated through trials, through the clinical trials data to move things forward. So in those three things that I've discussed, avelumab maintenance from the start of maintenance from first-line platinum-based chemotherapy, median overall survival 29.7 months. EV plus 302 from the start of chemotherapy, median overall 31.5 months from the start of that experimental arm. And cisgem plus nivolumab 21.7 months. So it is interesting when you look at that. There's no comparator data. We cannot randomize. It's not a randomized comparison, but it is quite interesting to see that actually regimens which may be 4 or 5 times cheaper than what EV Pembro is can give you significant and similar survival benefit and perhaps less toxicity as well. Plus the toxicity profile in Caucasian patient population compared to Asian population may be different. And it's something we should be really working very closely to and learn from that. Key thing will be eligibility criteria, shared decision-making, and available first-line treatment options. And I think this is such an important thing to think about. We can talk here about all day about EV Pembro, but as I said to you, even in UK, it's not available. In most parts of Europe, it's not available. Whether it will be available in Asia and things. I was giving a talk in India last week, and they haven't got availability of that. Very few people have used enfortumab vedotin. Some good data, some bad data, but the key thing is to bring those things and those data out. So available first-line treatment options are important, and the ground reality should never be ignored. And that's so important to get the best for your patients, not what is best based on evidence and literature, because we try to follow the evidence, but sometimes these drugs are not available. So just be realistic, look at what is best available within the constraints of the health economics and the patients, what they can afford as well. This is a trial. One of my patients who came to us had nephroureterectomy in January 2020. And he then started in sort of September 2020. In June 2020, his disease progressed. Then I gave him gem carbo chemotherapy. His GFR was 35. He really struggled with the 4th cycle. I had to only give 4th cycle because I can only get avelumab if patients had 4 to 6 cycles of platinum-based chemotherapy. That makes them eligible for. There was an early access scheme. He was the first patient who started on avelumab in UK on the early access scheme. And then he carried on with the treatment, and then NICE approved the drug. So from July 2022, we got it through the NICE funded platform as well. He had his 99th cycle a couple of weeks ago. So far, no toxicity issues. NICE has approved it for 5 years. I have to say, I feel that 2 years is enough. A trial which we designed called DISCUS, which looked at 3 versus 6 cycles of chemotherapy. That trial is allowing us to use 2 years of maintenance avelumab. So from Pakistan, if you give somebody 6 months data, capture that data and present it somewhere to say we stopped it based on health economics or patients' affordability. And I think that will be really important data. In UK, we are trying to do trials of 1 year versus 2 years versus 6 months. While you may have some data on 6 months already there, you may have toxicity data, which may be quite useful as well. So overall, in those terms, we know that cisplatin ineligible, full cisplatin consider gem carbo or split dose cisplatin can be used. The consideration should be cost of treatment. We cannot ignore cost of treatment for our patients and for our health economy as well. Health economics is important, cost effectiveness, patient selection, and maybe biomarkers as well that will help us. This is my last slide that I think what we can look at in an evolving landscape. We need to look at these considering the disease and patient characteristic, discuss with the patient. It's really important to make them help them make a choice. We should not tell them this is what you should be having. We should talk about risks and benefits, survival figures, prognosis, and all that bits. Toxicities are important. I think avelumab is a really good maintenance treatment, is a good for our metastatic inoperable advanced urothelial cancers. Toxicity profile is significant with EV Pembro, but when we use it, we should really follow what Javelin Bladder 100 did. That real world data has really enriched us to see that data which we saw in the Javelin 100 was being seen in advanced bladder cancer settings in real world as well. In fact, PFS and overall survival in certain cases are actually improving because we better understand how to manage toxicities. The same, there will be learning curve for enfortumab vedotin as well. So where you can get it on trials or research or compassionate basis, you can use it. But maybe sequence may be better giving chemo than immunotherapy than if you get it in Pakistan as well. So I think overall, you can look at all different patient populations. Don't I think it's really important that all patients should come through us. A big elephant in the room is that 25% of patients who do not see anybody, and they are literally not coming to anybody. And that is something how we can improve that exposure, where patients can at least come and see oncologists and multidisciplinary team. So we should all work together to try and improve the exposure of the drug, but also exposure of the patients to our cancer services, where they can come and be seen and talked about not only treatment options, but also palliative care, if that is the best option for them. And best supportive care should always be talked to patient when we are talking about these different treatment options. On that note, I will stop. Thank you very much.
Questions from the floor?
Thank you, Dr. Hussain. One question. What is your experience of treating patients, young patients with pre-existing autoimmune condition? Do you consult with rheumatologists? Because I just feel that I'm stuck after 4 cycles of carbotaxol. If they've got really bad autoimmune disease, what would you do?
I think, yeah, no, that's a really good question, because these are sort of patients who are not part of the trial. But there was a trial called SAUL, S-A-U-L, which was a big international European data, 1,090 patients, where basically patients who had autoimmune disease, patients who were on dialysis, patients who had brain metastasis. So all those patients who were ineligible for trial, so they had that data from atezolizumab. And actually, you can expose them safely with these drugs. Yes, rheumatologists will be really key in looking through all that. And, you will be, because by having those expert opinions, by having those expert input, it makes a big difference. The exposure of the drug improves, the toxicity profile improves. So I will say to stay in good touch with rheumatologists, but I have got a number of patients, for example, polymyalgia rheumatica. We try to reduce the dose of prednisolone. 10 milligrams was cut down to 5 and 4, and they have done extremely well. They're on the 12 months of maintenance avelumab now. We have some patients with autoimmune colitis sort of thing, but it has generally been well maintained. And I think more and more trials are now starting to accept that this is a group of patients we should not ignore, but learn from that. So if we see a lot of toxicity, then we'll stop early. But these patients can have these treatments and can be exposed to these drugs successfully.
Thank you so much, Dr. Hussain, for the beautiful talk. I'm Dr. Haris Siddiqui, medical oncologist at Shaukat Khanum, Lahore. I have a question that you very well emphasized on the fact that we should, keeping in the mind the guidelines and all, but we should all customize our treatment options as per our need, considering we are having availability issues as well as we are a resource limited country. But we at the same time, I mean, at times we face an issue that our patients are affording, and we cannot still, because of the availability issue, we cannot offer the right treatment. Likewise, my question is regarding use of maintenance therapy after platinum therapy. Can we use atezolizumab instead of avelumab with the same mechanism of action, as the availability of avelumab is an issue here?
Great question, Haris. I think the key thing you saw in Checkmate 901 as well, that I think what is driving the benefit is maintenance immune checkpoint inhibitor. So with nivolumab, you got it. If atezolizumab is available in Pakistan, properly regulated, where you see the efficacy of that drug in metastatic setting is there, I will have no issues about using maintenance atezolizumab. The key thing is the maintenance data. If you look at the synergistic data, if you look at the science behind it, perhaps with the immune signatures changes with 3, 4, 5 cycles of chemotherapy, and then you have a 4 weeks to 6 weeks, 8 weeks break in between, and then you challenge them with. So I think there's some really interesting data that I will be very happy to talk to you about, which actually showed that using that break, immune signatures changes, and then when you start immune checkpoint inhibitors in maintenance setting, that has a better outcome. If you remember first line trials, when they added chemotherapy with durvalumab and other trials, in the metastatic setting, they were negative trials. Atezolizumab was negative trial. But in maintenance setting is very different. We are seeing the benefit with Checkmate. So it is Checkmate 901 with maintenance nivolumab. You're seeing avelumab. So in a setting where rather than not to give a maintenance treatment avelumab because it's not available, I will definitely ask you to discuss that with Merck as well to try and provide it to you, to Pakistan. And you know how NHS works. You should all try with Shaukat Khanum, such a big center. You can start to talk about that. What price can you offer it to us, to our patients? And you will be surprised that sometimes they're so much keen on having these debates. Nice really runs on that. I can't tell you the price that we get it from, because NICE is a very confidential pact they do with the industry. But it's so important that never underestimate your own power. Shaukat Khanum, Pakistan, patient population is huge. And that is something that you can use as your power, as your strength, that actually this is our patient population, this is our numbers. These are the patients who can be exposed to immune checkpoint inhibitors if we do early, and you will see the survival benefit. As I said, I've got a number of patients coming to 3-4 years. We treat for 2 years of atezolizumab. In many cases, 1 to 2 years of avelumab. But sometimes, like I showed, that case is on his 4th year. But you can stop at some point, bring that data, real world data from Pakistan. I tell you, it will be a gold mine.
Thank you, Professor Sen, for an excellent talk. Obviously, this 30 months of median overall survival is very impressive. Do we have any predictive markers for this study, Javelin? That's a particular subset of patients who respond or whose survival is even better than this?
Yeah, and it's a great question, Rizwan. I think the key thing is that you saw in the forest plot, within those subgroups, there's a survival benefit in all these cases, whether the age was 80 plus, whether they are cisplatin eligible, 31 months versus 21 months, or they were cisplatin ineligible, 25 months versus 18 months. So all these patients were benefiting. I think in terms of biomarkers, yes, it is really important to look at, but 75 to 80% of patients will have benefit from platinum-based chemotherapy. But the problem is that if you leave them 3 to 6 months, you find that most of these patients progress. And that is the problem. So you're bringing the basket, you're increasing the basket of patients who can get maintenance immunotherapy. You can look at platinum-based chemotherapy-related toxicity, sort of biomarkers, cisplatin. So ERCC1 has been used in the past. So definitely this is a playground for all of us to look at. If you have patients, you start to look at platinum-based chemotherapy, how many responded, how many had CR, how many had partial response, and how many had progressive disease. You may find that is it ERCC in Pakistani patient population, which is driving cisplatin resistance. And I would never say that what has been done in Caucasian patient population, you should say that ERCC, you might find completely different results. And that's why subclassification of bladder tumors and things in Pakistani patient population, in Asian patient population is key. We have done some work with Saudi Arabia. They have done 20 Saudi patient population now subtyping. We're working with some other Middle Eastern countries and with Asia, including India and others, to do subpopulation to see what are the different subtypes.
Thank you, Dr. Hussain, for an excellent talk. You can talk to him privately because we are running behind time. The next talk is robot-assisted cystectomy, what lessons we have learned over the last 2 decades. This talk is being given by Professor Shamim Khan, who is a consultant urologist at Guy's Hospital, London. Dr. Shamim Khan.
Assalamu alaikum, my brothers and sisters from Shaukat Khanum Hospital. My name is Muhammad Shamim Khan, and I'm one of the professors of urology and a consultant urologist in Guy's and St. Thomas's Hospital, London. I have been asked to give a talk on robot-assisted radical cystectomy, lessons we have learned over the last 20 years, and how we do it. In the first instance, I would like to express my gratitude to Professor Syed Hussain, who is a very eminent medical oncologist in the University of Sheffield in UK, who kindly invited me for this. And I am grateful to Maria Kuptia, who kindly extended the invitation on his recommendation. I'm very grateful to my team and guys in St. Thomas's Hospital who have contributed to this service over the last 20 years. What lessons we have learned, I will share those lessons with you in the first instance, and these are based on our experience of 1,131 radical cystectomies. Of these, 752 have been done with the robot assistance. Of these, 582 were performed by myself. The open cystectomies, we have done nearly 370 and 190 by myself and 19 laparoscopic. The first lesson we have learned from this program that radical cystectomy is the most challenging and morbid operation in Uro Oncology, irrespective of the surgical approach. Secondly, whenever you are starting a new program, it always seems impossible until it has been done. And thirdly, when you are starting a new program, you will face criticism or skepticism from your friends and colleagues within the department and around the country. In the second phase, they will start accepting it. And lastly, they will embrace it with enthusiasm. So don't be disheartened at the early phase of any such program. I must warn you that buying a machine does not mean that your results of the procedures will transform overnight. It does need experienced surgeons driving these machines. And as they say, a fool with a tool is still a fool. In order to gain the experience of the training, you have to train the entire team and not just the surgeon. That includes your surgeon, anesthetist, and other team members, including nurses and the bedside assistants. And you follow a training pathway of dry lab, wet lab, fellowship in high volume centers if possible, mentorship, and most importantly, record the procedures whenever you are doing a procedure and audit your outcomes. Go back to see if they have made any errors or mistakes, review those as to how they happen. And when you are starting the program, start by doing what is necessary, then do what is possible, and suddenly you will be doing what seems impossible at the start. However, I would suggest that you avoid these cases in the beginning. I mean to say advanced cases with advanced disease, patients who had previous multiple abdominal or pelvic surgery, patients who had previous pelvic radiotherapy, those who have high body mass index, and patients with poor cardiopulmonary function. All these cases you should avoid in the beginning are actually the ideal cases for robotic approach to minimize their morbidity, but once you have achieved enough experience and expertise. Surgery performed in high volume centers yields superior outcomes and better patient satisfaction. And therefore, what I would suggest that in a big city, like for example, Lahore, you should not have more than 1 or 2 centers performing such highly specialized work. So that after having been involved in over 750 robotic cystectomies, what I can say from our experience that is associated with minimal blood loss, you hardly ever need to transfuse any patient, shorter scars, less than 1% wound infections, shorter length of stay, and less complications. However, there is longer operating time, maybe about 30 minutes because you need setup time, higher cost, and equivalent oncological outcomes. The take-home message from me is that robotic-assisted cystectomy has become the new standard of care in developed countries. About 80 to 90% of cystectomies in our center are performed with robotic assistance. Open radical cystectomy, however, will continue to have the place for highly selected cases which are unsuitable for robotic assisted cystectomy, and this happens in about 10 to 20% patients. And the key to improving outcome is performing this procedure in high volume centers by highly experienced surgeons. So I thank you for your attention listening to these lessons. And now I'm going to play the video, which will run about 15 to 20 minutes. I will be present online when this presentation being applied so that I can answer any question you may have about the procedure. Is the video not playing?
Seem to be playing.
We present our step-by-step guide to robotic cystoprostatectomy, pelvic node dissection, and intracorporeal ileal conduit formation. The camera port is placed midway between the xiphisternum and the umbilicus using an open Hassan technique. The patient is then placed into steep Trendelenburg at approximately 24 degrees head down to allow the bowel to fall away from the pelvis. The abdomen is then insufflated, and the pubic symphysis and ASIS are then marked. Along a horizontal line, 19 centimeters from the pubic symphysis, the remaining ports are then spaced 8 to 10 centimeters apart. The right robotic port we try to place within the pre-marked stoma site to minimize the incisions required for the patient. A 12 millimeter air seal is placed into the right lateral abdomen, and a 15 millimeter port is placed in the left lateral abdomen, which allows an 8 millimeter robotic port to be placed within it for the fourth arm, and this can be removed to allow the laparoscopic stapler to be introduced during the conduit formation. The ureter is most easily identified at the iliac bifurcation. The peritoneum is incised over the ureter to allow the gas to dissect this plane. The ureter is mobilized using a combination of blunt and sharp dissection, minimizing the amount of electrocautery used to prevent compromise of the ureteric blood supply. The ureter can be slung with a vessel loop to allow better traction on the ureter. The ureter is then mobilized distally to its insertion into the bladder and proximally far enough to allow enough length for the uretero-ileal anastomosis. The peritoneum is incised lateral to the medial umbilical ligament to enter the space of Retzius. This plane is then developed distally to the endopelvic fascia. The vas is then mobilized. Clipped and divided. The lateral plane is then further dissected to expose the external iliac artery, vein, and medial umbilical ligament. The medial umbilical ligament is double clipped and divided. This pedicle, which contains the branches of the superior and inferior vesical vessels, is further dissected, clipped, and divided towards the apex. The bladder is lifted with the fourth arm to expose the posterior plane. The peritoneum is incised over the vas and the seminal vesicles. The rectovesical plane is then developed by dissecting on the vas and seminal vesicles. The ureters are then clipped and divided. The endopelvic fascia is incised to allow better identification of the prostatic pedicles. Here, an interfascial dissection is used for the development of the rectoprostatic plane. Here, blunt dissection is used to minimize the risk of rectal injury, and the assistant should gently retract on Denonvillier's fascia overlying the rectum to aid the dissection. The prostatic pedicles are then clipped and divided. The bladder is then dropped anteriorly. The superficial dorsal vein is cauterized with the bipolar and then divided. The DVC is then secured with a CT1 Vicryl suture to minimize bleeding during division of the DVC. The urethra is then dissected. The catheter is then removed, and then the urethra is double clipped to prevent spillage and then divided. For the lymph node dissection, we start by incising the tissue lateral to the external iliac artery to expose the genitofemoral nerve and the psoas muscle. The dissection is then continued between the external iliac vessels and the pelvic sidewall. The nodal packet is then freed medially from the external iliac vessels. The obturator nerve is identified medially and preserved during the dissection. The dissection is then continued distally to the femoral canal to obtain the node of Cloquet and proximally to the junction of the common iliac artery. A plane is developed under the sigmoid mesentery, which is most easily done by following the common iliac artery from the right side to the left side. The assistance grasper is then passed through this mesenteric window to the left side. The ureter is then grasped and then passed across to the right side through this mesenteric window. Care is taken not to twist the ureter during this maneuver. For the conduit harvest, the patient's position is reduced to about -10 degrees head down. A loop of ileum extending proximally from the ileocecal valve is laid out to assess the bowel segments. Measuring with a 10 centimeter suture, we mark out the appropriate segment, preserving 20 to 25 centimeters of the terminal ileum. A 60 millimeter and then a 45 millimeter stapler is then used to create the distal end of the conduit. A full thickness 3-ovicral marking suture is placed, which allows marking of the distal end of the conduit and aids bringing out the conduit at the stoma site at the end of the procedure. The conduit is then measured to 20 to 25 centimeters and another 60 millimeter stapler deployed to create the proximal end of the conduit. The corners of the enteroenterostomy segments are cut, and a 60 millimeter stapler is introduced into each of the enteroenterostomy limbs, ensuring the antimesenteric side is being stapled. This is again repeated with a 45 millimeter stapler. A 60 millimeter stapler is then placed across the end of the enteroenterostomy, and a further 45 millimeter stapler may be required to complete this. A trouser suture is placed with a 3-ovicral to reduce tension on the staple line. The staple line at the end of the enteroenterostomy is then inverted with a continuous 3-ovicral suture. To set up, the end of the conduit has been retroperitonealized by suturing it to the peritoneum of the sigmoid mesentery. The ureter is then spatulated and a healthy blood supply is ensured. A corresponding enterotomy is created. A 4-ovical suture is placed at the apex of the enterotomy and the ureteric spatulation and tied. This is repeated with another 4-ovical suture to the left of the apex. These two sutures are then run continuously on either side of the anastomosis until half of the anastomosis is completed. A 7 French band stent is then placed into the ureter. The corner of the distal conduit is then cut, and the assistant introduces a grasper through the conduit to the enterotomy. The stent is then grasped and then passed through the conduit. A forovical repeat suture is then used to anchor the stent to the conduit. The distal ureter is then trimmed and sent for analysis. The anastomosis is then completed by continuing the 2 existing suture lines. This is then repeated with the other ureter.
The video stop. End of slide.
Right. That seems to be the end of it.
Assalamu alaikum. Yeah, so I am here if you have any questions.
Thank you very much, Prof. Very interesting presentation. Since we are running a bit late, could we
Yeah,
have any
it was
questions
only
towards
about
the end
20
of the
minutes, so
session?
I had to compress both the video and also some lessons. So
Thank you so much for having me.
more than happy to answer any questions if anybody has any questions. Yeah.
Yeah, we'll take questions at the end of the session, Prof. If
Thank
you
you.
could
Yeah, no problem. Yeah, that's good.
stay
That's
with us.
great.
Thank you so much.
Thanks.
Moving on, the next talk is about the practice of second-line therapy in metastatic castrate-resistant prostate cancer. And it's a virtual talk as well, and it's by Mutahir Ali Tunio, who's a consultant clinical oncologist at Swansea Bay University Health Board in Swansea in the United Kingdom. Dr. Tunio, floor is yours.
Thank you so much for having me. It is a really pleasure today to speak to you on optimal management of MCRPC. I will talk on different scenarios at time of starting first-line treatment, briefly touching somatic and germline mutations, neuroendocrine variants, one poll for a discussion, and then I will conclude my session. According to National Prostate Cancer Audit data of UK, around 50,000 cases are diagnosed as a prostate cancer each year, of whom 20% are the metastatic one. And about 12,000 of patients, they die from prostate cancer. And if you can see, the majority of prostate cancer deaths occur in MCRPC setting. Since 2004, now we have a number of treatment options available, like taxanes, immunotherapies, androgen receptor pathways inhibitors, radiopharmaceutical agents, radium-223, Pluvicto or lutetium, PARP inhibitors, combinations of PARP inhibitors and androgen receptor pathways inhibitors. And these drugs have shown a survival benefit. But shall be an optimal sequence approach when we decide to treat these patients. An American review has shown that only 2/3 of MCRPC were able to receive first line of treatment. When it came to second and third line of treatment, the number was further reduced. Different factors, they play a role when we decide to treat patients with MCRPC, including patient factors, tumor factors, and treatment factors. The most important factor is that what has been given in hormone-sensitive prostate cancer setting. In the clinical practice, there are at least 4 scenarios when we are deciding first-line treatment for MCRPC patients. Number 1 is when the patients, their progress is on androgen deprivation therapy, which is in use since 1940s. Other scenarios, patients progresses on taxanes chemotherapy. Third scenarios, patients progresses on androgen receptor targeted agents. And last and most complex scenario when the patients progresses following the reception of ARPIs, taxanes, or following triplets. NICE guidelines really don't show any optimal sequence or algorithms. Here is what NCCN guidelines look like in 2024. It is a 2x2 table for MCRPC, where you have to consider what a patient has not received previously. It's a bit mess. Let's start with the first scenario where the patient's progresses after androgen receptor therapy. We all are aware of ATTACKS 327 and SWAG study results where docetaxel 10 cycles have shown improvement in the survival, approximately 1.5 years, and improvement in the progression-free survival rates. Whether we can replace docetaxel with the cabazitaxel, which is a bit less neurotoxic. First NICE study investigated cabazitaxel in chemotherapy-naive MCRPC patients with the 2 different dose regimens with the docetaxel, and as you can see, median overall survival rates were comparatively same, and the low-dose cabazitaxel was associated with the reduced incidence of a peripheral neuropathy, 12% versus 25%. Pre-docetaxel approval of abiraterone is based on Cougar A302 trial, which showed improvement in the overall survival in the patients with the asymptomatic or minimal symptomatic MCRPC patients. There was an improvement in the radiological progression-free survival as well. STAR study compared the fine particle formulation of AB with methylprednisolone to original formulation of AB with prednisolone. And it was found that the fine particle formulation was associated with the reduced incidence of musculoskeletal events and the reduced risk of UTIs. Another phase 3 trial, Prevail, studied enzalutamide in pre-docetaxel setting. Enzalutamide was associated with the improved median survival by 2.9 years and median progression-free survival about 20 months. Urologists, they ask in MDTs, is enzalutamide better than bicalutamide? We have at least 2 trials, Terrain and Strive, which favor enzalutamide. Are 2 ARPI any good? The SEIS phase 3 trial was designed to study combination of 2 ARPI, that was the apalutamide plus AB versus AB alone. This combination was called androgen annihilation. SEIS trial met its primary endpoint of radiological progression-free survival benefit, with androgen annihilation prolonging radiological progression-free survival from 1.4 years to 2 years. But overall survival was similar between 2 arms, and the treatment-related toxicity was high in annihilation arm. This year, ESMO 24 results of phase 3 trial were presented. It is a phase 3 trial of a radium-223 plus enzalutamide in asymptomatic or mildly asymptomatic MCRPC patients. zoledronic acid or denosumab was given along with the interventional and control arms. The Peace 3 trial met its primary endpoint. Addition of radium-223 to enzalutamide was associated with significant improvement in radiological progression-free survival, that the median was 1.6 versus 1.3 years, and the median overall survival with the combination was 3.5 years versus 2.9 years in enza alone. This is a game changer trial. ESMO guidelines will likely to be amended soon to reflect this combination as a potential new standard of care. Sipuleucel is an immunotherapic agent that was approved by FDA in 2010, and it has shown a survival benefit in asymptomatic or minimal symptomatic MCRPC patients without visceral metastases. However, it is a very expensive treatment, and only the few the small phase 3 trials are being done. Second scenario, when a patient progresses after taxanes therapy. FDA approval of abiraterone in post-docetaxel was based on results of Cougar A301 trial, and approval of enzalutamide was based on the results of AFFIRM trial. Both these agents showed improvement in the median overall survival and progression-free survival as compared to placebo arms. Cabazitaxel post-docetaxel was approved based on a TROPIC trial, and Prosalica trial compared two different dose regimens of cabazitaxel. And as you can see, low-dose cabazitaxel was associated with the reduced risk of hematological toxicity. Approval of radium-223 was based on Alsimca trial, in which the patients with the symptomatic MCRPC patients with the 2 or more bone metastases without visceral mets were included, and median survival with the radium-223 was 1.3 years. Therapy is a phase 2 trial, but it was a very well designed, because in the control arm of standard care, the cabazitaxel was used. And the patients who received the lutetium, there was a 37% decrease in the risk of a progression. Third scenario, when a patient progresses after ARPI. A post hoc analysis of a Cougar A302 trial found that docetaxel was very effective after progression. AB resulted in a good PSA response, improvement in progression-free survival. And a switch is studied if we can switch dexamethasone with prednisolone after patients progressed on AB and prednisolone. There was a reasonable PSA decline at 6 weeks. However, it is not a standard practice. We all aware of a cross resistance between ARPIs. Enzalutamide has been studied after AB, and the median time on enzalutamide in such patients was only 4 months, with the poor response rates, not a viable option. Radium-223 can be considered in this population. Results of Rapson studies were presented this year in ESMO. It's basically a trial whether radium can be given before or after docetaxel chemotherapy. And this study shown that the upfront radium-223 was associated with the improved quality of life and tolerability, and no treatment difference in terms of progression-free survival or overall survival between two arms. PSMA-4 enrolled patients who progressed on ARPIs with the PSMA positive lesions. and they were randomized to lutetium and ARPIs, although it was a bit controversial. It has shown a radiological progression-free survival of about 12 months versus 6 months with ARPIs, improved quality of life. However, there was no overall survival benefit. The SPLASH trial was a similar design to PSMA-4 trial. However, they used a different agent, PSMA-INT. Now it is renamed as a PNT 2002. Median progression-free survival benefit was about 4 months with PNT 2002 as compared to ARPIs. Fourth scenario, if patients progresses on ARPIs and taxanes, which is a bit complex. We all are aware of a VN phase 3 trial that used lutetium versus standard of care. It has shown a survival benefit in terms of progression-free survival. However, hematological toxicities was high in the lutetium arm. CAR trial results were uniformly positive, with the primary endpoint of median progression-free survival in favor of cabazitaxel compared to ARPIs, and also there was a survival benefit in favor of cabazitaxel. CONTACT-2 trial is evaluating the combination of cabozantinib with atezolizumab compared to ARPI in MCRPC patients who were treated with the taxanes in ARPI previously. A pre-specified interim analysis showed a trend towards improvement in overall survival. However, data was immature and did not meet a threshold for statistical significance. Therefore, a trial will continue to the next analysis of overall survival as planned. Somatic and germline mutations are positive about 12% of patients and as high as 25% in MCRPC patients. And these must be requested if not done earlier to guide subsequent treatment in MCRPC patients. The combination of enzalutamide and talazoparib was studied in TALPRO-2 trial, and it has shown improvement in progression-free survival as a first line in a patient with MCRPC and homologous recombination repair defects. Similarly, patients with the homologous recombination repair MCRPC patients, combination of abiraterone and olaparib has shown an improvement in the progression-free survival, again in the first-line setting, and there was a trend in overall survival benefit as well. Breakaway study was presented in ESMO this year, and it has shown similar results to PROPEL. Magnitude trial was a combination of niraparib with abiraterone. It has shown a similar results, improvement in a progression-free survival in first-line setting in HHR MCRPC patients. PARP inhibitor in the second line, we know the results of PROfound and TRITON3 trial using olaparib and rucaparib respectively, showing an improvement in progression-free survival. Olaparib was also had additional overall survival benefit as well. The neuroendocrine tumors are very rare, and they arise in adaptation of a treatment, as the primary neuroendocrine of prostate are very rare. These are androgen receptor negative, often present with the visceral mets, with the lytic lesions, no PSA elevation, PSMA PET scans are negative, they're not responding to ARPIs, And for these patients, platinum combinations shall be used. So here is a case, 69-year-old diagnosed as a metastatic prostate cancer T2N0M1 with erythroperitoneal nodes and 2 spinal lesions in 2015, treated with LHRH analogs. PSA were undetectable for 4 years. In 2019, his PSA started to rise. Imaging were negative and was started on darolutamide in the setting of a non-metastatic CRPC. And in 2003, his PSA started to rise again, and with the PSA of 5 months. And you can see the PET scan, PSMA PET scan showed uptake within the prostate. There was some uptake in the spleen, but that was the hemangioma. So basically, we are dealing here is a oligometastatic CRPC patients. How would you like to treat this patient? Will you continue darolutamide, or you will switch to another ARPI, or you will switch him to docetaxel or bipolar androgen therapy, or SABR, or stereotactic radiotherapy? R2 is a small trial which has shown an improvement in the PFS in these oligometastatic CRPC patients with the use of SABR. Bipolar androgen therapy is only not tested in phase 3 trials. And one phase 2 trial, Transformer, has shown some efficacy in asymptomatic or mildly asymptomatic patients. Basically, idea is to give low dose testosterone to disrupt the adaptive upregulation of androgen receptor that occurs with the low testosterone levels. So here is the summary, and if you can take a screenshot how to use a subsequent systemic therapies in MCRPC patients in your clinics, depending on availability of the drugs and expertise and the cost. Finally, I will say that use your best drug as early as possible, like a combos. Don't hold back. If you think chemotherapy shall be given as a first instance, use it. Don't wait it for later. And also use somatic or germline testing at the time when the patients are labeled as MCRPC. Thank you so much.
Thank you very much, Dr. Tunio. If there are any questions, could be taken at the end of the session, please. Dr. Tunio, if you could be kind enough to stay with us to the end of the session.
Yeah.
Thank you so much.
Thank you. Thank you.
Could we quickly move on to the next one, which is interesting cases in germ cell tumor, and it's going to be presented by Dr. Faisal Azam. He's a consultant medical oncologist at King Fahd Specialist Hospital in Dammam in Saudi Arabia. Dr. Faisal, please. Thank you.
Bismillah ar-Rahman Assalamu alaikum. Well, thank you very much for the organizing and scientific committee, and special thanks to Maria for inviting me to talk about the challenging cases of germ cell tumor. So I know you all are tired, but I'm not going to discuss trials, curves, videos. So these are just real-time 4 cases selected, very short. And if you can just follow me, we have treated and how we've treated. I was speaking to one of our junior colleagues, and I said, I'm going to talk about challenging case of germ cell tumor. He laughed. He said, well, why? There's no challenge in it. So I said, well, come and then we will hear what are the challenges. Actually, there are a lot of challenges in the germ cell tumor. My disclosures. So germ cell tumor is the success story for medical oncology. It will not be wrong to say that It is the only success story that we can cure the cancer in any stage. So it's the most curable solid neoplasm, and that is because of the remarkable advances in 1970s when we invented cisplatin-based chemotherapy, and since then things have completely changed. It accounts for 11% of cancer deaths in a patient in the ages of 25 to 34, with overall survival of 64% in that age group. But overall, it's 0.1% of all cancer deaths in all men. And 5-year survival, you can see 95%. So that means we can cure almost all the patient at any stage. And that itself is a big challenge now. Whenever you are so successful and you've touched the ceiling, there is always a problem that you will face challenges. And what are the challenges? These might be, you all are oncology, you might be seeing this is no challenge, isn't it? Advanced disease, performance status, poor performance status, comorbidities, old age, organ toxicity. We see them on a daily basis in a breast cancer, prostate cancer, in other cancer, bladder cancer. And what do we do? We say, well, not fit for treatment. In UK, we say not fit for even haircut. So do not treat because we do not want to harm the patient. But would you do the same in 19-year-old who have more than 95% chance of cure? No, you cannot. So that is the biggest challenge. You want to treat, but at the same time, you do not want to harm the patient. And this is one of the challenges. What about the rare variants of germ cell tumor? There is no evidence. Like Syed explained, a lot of good trials. We do not have any trials. So how will you treat when you don't have an evidence to back you? But you have to treat somebody who's 14, 15-year-old, young boy, family looking at you, and you're saying it's curable cancer. But what to treat with? This is another challenge. Then we have benign teratomas, which does not respond to chemotherapy, does not respond to radiotherapy. If you cannot resect, what will you do with them? They die from benign tumor, not from malignant tumor. So these are the few challenges. I have selected only 4 cases, and I'll just take you through very briefly. 19-year-old patient, these are my patient who came in with intestinal obstruction. He's a smoker, 20 cigarettes a day. He had DVT, started on Clexane. CT scan reported extensive abdominal lymph nodes causing intestinal obstruction. He has lung metastases, testicular mass. And when patient comes with this, of course, 19-year-old, you would do tumor markers. So we did beta HCG 21,000, LDH 3,400. His performance status was 4. He was bedridden, and he has been like that for the last few months before he came into the hospital because of the abdominal pain and generally very unwell. Blood tests show that he's in renal failure, eGFR of only 35. So where do you see the challenge here? He has renal impairment, cisplatin, or renal failure actually. Cisplatin is one of the main drugs. Can you give cisplatin to this patient? Right. Then he's a smoker, renal impairment. Can you give bleomycin, which can cause bleomycin lung toxicity? We can kill him if we give him. So the 2 main drugs we cannot give. So how should we treat this patient then? And he has thrombosis already, and with advanced disease, bedridden, you want to give chemotherapy, but that will increase the risk of thrombosis. So just by looking at the first page, you are facing so many challenges, and you do not want to ignore this patient because you know this young boy is going to walk if you treat him properly. But how to treat? There is no evidence. There are no phase 3 trial, no survival curve which help us how to manage these patients. Anyhow, he had biopsy done that showed it's classical seminoma. Now again, what is the challenge here? It says classical seminoma. By definition, alpha fetoprotein in classic seminoma should be normal, not should be, must be normal. So this is not classic seminoma. If the pathologists say it is classical seminoma, but serum alpha fetoprotein is high, the diagnosis is not seminoma, it's non-seminoma. So again, so don't rely on pathology. It's the tumor marker also is important here. So how did we treat it? Somebody who's bedridden, renal failure, not very well, lung metastases. So we started him on low dose etoposide 100 milligram per meter square and cisplatin 20 milligram per meter square. I started every 3 days. I was giving him 1 dose. His performance status was 4, and it took me around 6 weeks to make him better, and his performance became 1. So surprisingly, his tumor markers improved. He was bedridden, but slowly improving. By April 2017, he was fit enough for chemotherapy, and then we hit him with a proper chemotherapy, 5 days of EP chemotherapy every 3 weeks for 4 cycles, and his tumor marker normalized. So a success story in a patient which we thought is going to die very soon. So by July 2017, his tumor marker is normal, performance status is 0. He underwent orchidectomy. CT scan still showed that there are significant amount of lymph node disease, small lung nodules, renal vein thrombosis is still there. So we asked the thoracic surgeon, and they said the lung metastases are very small, so you better observe it rather than doing surgery. We asked the urology team if they can do retroperitoneal lymph node dissection, and they said, yes, we would do, but patient refused. Anyhow, patient refused, we just follow up, carried on follow up. So you can see for next 6 months, he was okay till his tumor marker starting rising. CT scan showed some progression of disease. So we decided to give him second-line chemotherapy, which was Taxol, ifosfamide, and cisplatin, 4 cycles. Once again, he had a complete biochemical response and significant response on a CT scan in retroperitoneal lymph nodes. And once again, I referred him to the urology surgery team, and they have offered him surgery. Once again, he refused. So he does not want surgery. So what is the challenge here? Young patient, 19-year-old teenager, you probably would have teenager children. How do they behave? So high tumor burden, twice he had a complete response. So this gave him a false reassurance that every time I come poorly, doctor will give me chemotherapy, I will get better, and I will be okay, which is not the right, but this is what they think. So, and then there are emotional, psychological challenges. Those oncologists who are treating these young patients, they probably know the challenges with these patients, especially psychological and emotional. So we should have a teenager, young adult units, which we have in most of the big hospital centers, where they have social workers, the oncologist, the pediatrician, and they all deal with the young patient right from their home to the hospital and everywhere. So at every step, they support them to help them, these patients. Anyhow, this patient lost to follow-up. He said he's fine. He's not coming to the hospital till for nearly 1 year, when he came back with now this time jaundice. His tumor markers are risen. Bilirubin is 266, and liver enzyme were also deranged. We did a CT scan again. Retroperitoneal lymph nodes are progressing, and it's pressing on the liver. Once again, because of the liver failure, we cannot give full dose chemotherapy. We gave same low dose EP chemotherapy till the bilirubin normalized. And then we gave him this time vinblastine-based chemotherapy with ifosfamide and cisplatin. Very good response again. With 2 cycles, he had a very good response. He was feeling better, and he ran away from us again. So lost to follow-up, and still we have lost to follow-up. He did not come back. So the challenges, again, emotional, psychological challenges. Do we have anybody to go and convince him? Do we have a social worker? Do you have a psychologist who can see this patient? Or they are young children. He's cured probably, and we can cure him further, but he stopped the treatment. I don't know what happened to him, actually. My story finish here with this, but I'm trying to tell you the challenges against it. This is the patient who was dying. We cured him. After 2 years, he lost to follow-up again. So that's why these are the few challenges. Next patient is 39-year-old patient with metastatic mixed germ cell tumor of left testes with lung metastases and retroperitoneal metastases. Alpha-fetoprotein 78, look at the beta-HCG 800,000, LDH 650. So we gave him EP chemotherapy 1 cycle, and after 1 cycle, he came in with a hemoglobin of 5, hemoptysis, dyspnea, and cough very poorly just after 1 cycle of chemotherapy. This was his CT scan after first cycle of chemotherapy. So significant amount of lung disease also. So what we did was we started him on VIP chemotherapy, etoposide, ifosfamide, and cisplatin chemotherapy. We gave him 4 cycles, and he had complete biochemical remission. Hemoptysis continued till 4 cycles, but after that, he was fine. CT scan did show residual disease in the retroperitoneum and both lungs. He underwent orchidectomy and resection of the retroperitoneal lymph node, and biopsy said no malignancy, no viable tumor. It was just fibrosis. So he had complete pathological response and complete biochemical response. So what is your diagnosis? Somebody who had significant amount of lung disease, beta HCG was 800,000, and after one cycle, he came in with hemoptysis and hemoglobin of 5. So what do you think is happening? Well, this is a very rare syndrome, actually, and you should recognize that. It's called choriocarcinoma syndrome. If we do not recognize this in time, this can kill a person. And it is a very big challenge, actually, not to treat it with high-dose chemotherapy, because they will come in with significant amount of bleeding and will die because of the bleeding. The way to diagnose is somebody who presents with advanced germ cell tumors, significant amount of lung disease, a high volume choriocarcinomatous element on the pathology. And when the beta HCG is in hundreds of thousands, always think about choriocarcinoma. So the first case was described in 1986 by Logothetis, and these tumors are highly vascular, present with life-threatening hemorrhage and metastases. Lung metastases leading to alveolar hemorrhage is the most common manifestation, like our patient was. But it can bleed in liver, kidneys, brain, bones, small intestine. It can bleed anywhere, and the patient can die very easily if you cannot treat them appropriately with the first cycle of chemotherapy. But most common cause of death is because of asphyxia due to alveoli flooding with the blood. And that is why it is very, very important to diagnose it as soon as the patient presents to you. It can happen in two settings: spontaneous in advanced disease. And I had seen this patient, a very young 18-year-old girl, presenting with supposedly pneumothorax. When the surgeon put the drain in, it was pneumothorax. Significant amount of blood came and was gushing out. Hemoglobin was only 3. And we did a tumor marker, and beta HCG was in millions. We treated her, and she's okay, alhamdulillah, now 4 years, she's cured. But the most common presentation is after first cycle of chemotherapy, when they present with the bleeding. Dry cough, hemoptysis, usually the first presenting symptom. So early recognition, prompt treatment is essential, as fatal lung bleeding may occur in the first few days of first chemotherapy. Avoiding full dose chemotherapy is extremely important. If you give full dose chemotherapy, it's very difficult to stop that bleeding again. They usually die because of the bleeding. You can cure them from cancer, but not from the complication of this disease. So European Germ Cell Cancer Consensus Group recommend to start with low-dose EP chemotherapy for 1 to 3 days. And when the patient is stabilized, then give full-dose chemotherapy. Modified chemo regimen has been shown to reduce the ARDS from 87% to 30%, and overall survival is improved from 27% to 40% as compared to full-dose chemotherapy. The regimen we give usually is 2 to 3 days of cisplatin with etoposide, or we give carboplatin with etoposide for 1 to 3 days. And after that, we give VIP, which is etoposide, ifosfamide, and cisplatin. Almost all the patients we have treated have been cured. And the reason for that is because our center is well known to treat these malignancies or these syndromes or germ cell tumors. And that's why it's easy for us to recognize as compared to the place where they don't treat many patients. Tumor lysis syndrome is not common for in these patients. My third patient is 21-year-old patient with the non-seminoma, testes with lung metastases, alpha-fetoprotein 4,000, beta HCG 1,000, and LDH 356. Surgery was done, orchidectomy, and then 4 cycles of BEP chemotherapy was given. Presented with dry cough after 4 cycles of chemotherapy. Probably an easy diagnosis here. This is a chest X-ray. Before 4 cycles, you can see on the left side, and what happened after 4 cycles, you can see here the patient had dry cough and breathlessness. So most of you who are treating probably would know what is happening to this patient. It's a bleomycin lung toxicity, very common actually. It can happen. The risk factors are those patients who have repeated systemic administration of bleomycin. Cumulative dose should not exceed 450 units. Patients who are more than 40, I usually avoid bleomycin. Those patients who is already on oxygen, again, can cause problem. Those who have radiotherapy, renal insufficiency, smoking history, underlying lung disease, and GCSF usually aggravate the process of this bleomycin lung toxicity. Well, how does it happen? The bleomycin causes inflammatory response, and then cytokine production happens. And we have seen a lot of deaths in COVID because of cytokine storm. And this is what it is, the same mechanism here. G-CSF we usually give with chemotherapy. And similarly here, when you give, it will aggravate the process. The diagnosis is via DLCO, diffusing capacity of the lungs for carbon monoxide. It's very sensitive test to find out. And if it is low, you stop the bleomycin. Omitting bleomycin, if significant drop in the DLCO can probably prevent bleomycin lung toxicity. It usually happens in 6 to 7% of the patient, and 14% patient will die if not treated appropriately. Patient who does not have any risk, even in those 2% will get the bleomycin lung toxicity. So what do? We do pulmonary function test before we starting bleomycin-based chemotherapy, and then I do chest X-ray with each cycle. We educate patient very well that if they have any signs of dry cough or breathlessness, they have to come and low threshold to stop the bleomycin. The challenges here is when will you treat this? When the patient is asymptomatic, they have radiological change, will you treat or will you wait for symptoms? Would you like to do DLCO with each cycle, which is not easy actually. It takes a long time. We don't do it, but this is one of the things, ideal situation it could be. How do we treat? High dose glucocorticoid for 4 to 6 with a tapering dose, oxygen, immunosuppressive, and in the end, lung transplant is needed if they do not respond to these treatments. So my last case is 22-year-old patient. He's a very interesting patient actually, who had a left orchidectomy for mixed non-germ cell tumor. Pathology reported 80% teratomas, 20% embryonal carcinoma. No treatment was given at that time, no adjuvant chemotherapy. 6 months later, coming in with GI symptoms, weight loss, lower back pain. Tumor marker was risen. So we did a CT scan, reported 20 centimeter retroperitoneal mass, lung metastases, and cervical lymph nodes. So we gave BEP times 3 cycles. Serum tumor marker normalized, so complete biochemical response. We did a CT scan and it showed the mass in the abdomen remained the same, 20 centimeter as it was before the chemotherapy, no lung metastases and no cervical lymph node. So complete response everywhere else except in the retroperitoneum. So we decided to observe sometime when you give chemotherapy, it takes some time for the tumor to shrink. 4 months later, we did another CT scan, and the retroperitoneal mass has increased from 20 centimeter to now 35 centimeter. Tumor, we referred the patient to surgeon, and the tumor was resected. Histopathology, mature teratoma. So this was mature teratoma, and that is the reason it did not respond to chemotherapy, but the tumor marker normalized because the immature teratoma was treated. After follow-up of 12 months, he has no recurrence and he's doing very well. This was the tumor on the CT scan. We can see a huge tumor in the retroperitoneum. So you all know what is happening. It is called growing teratoma syndrome. Chemotherapy does not cure the mature benign teratoma, but it cures the immature teratoma or malignant part of it. It can be sometimes very aggressive with local spread potential to change into malignancy. And this syndrome has been reported mostly in the retroperitoneum, but it can happen in lung, cervical lymph node, mediastinum, supraclavicular lymph nodes, inguinal lymph node, mesentery, liver, pineal gland. It can happen anywhere, and complications are usually because of the local compression. Treatment is aggressive surgery to prevent its development into the unresectable disease. They are quite resistant to chemotherapy and radiotherapy, so that's why surgery is very important to do it in time, because if you leave it, it can involve the major vessels, it can involve the major organs, and then it becomes unresectable, and it can change into malignant then. So interferon, bevacizumab, CDK4/6 inhibitors, especially palbociclib, have some role, but those have shown only in phase 1, phase 2 studies, but those can be used to make the patient unresectable patient into resectable, and then surgery will be needed. 5-year survival is nearly 90% who underwent complete resection in those patients where it is resectable. My last slide. So those 4 cases have shown that germ cell tumor is highly curable cancer, but there are complexities around different cases, especially atypical cases, as I've shown you, the patient with choriocarcinoma, patient with the growing teratoma syndrome. So you need to have an individual approach to the patient, and also the involving the multidisciplinary team like psychologist, child psychologist, social worker needs to be involved, especially for psychological, emotional support of these patients. These are young children. You need to treat them appropriately. You need to encourage them. You need to educate them that treatment in time can be cured. You have a long life. You can be okay with the treatment, and keep them encouraging them to carry on with the treatment. So timely management can impact the outcome, especially in growing teratoma syndrome. It is extremely important not to miss the boat and make it unresectable. Ongoing education, research, and the approaches towards the research and educating the patient to have the treatment in time probably will improve the outcome in these patients. And as I said, in the end, this is probably the only cancer we have achieved such a high cure rate that we must say that, and we must congratulate ourselves that this is the cancer we can cure. And when I see the germ cell tumor, I'm very, very happy actually, because I can tell the patient, most probably I'm going to cure the patient, even if they are bedridden. I have literally in the last 15 years treated many, many young children whose parents were crying, coming to me that they are dead, and they look like dead. But now they are in university. I have few. There are engineers, doctors now, whom I have treated. So it's very, very much rewarding cancer when we're treating the germ cell tumors. Thank you very much.
Thank you very much. Very interesting talk. It's so the take-home message, I guess, from this is that one needs to continue to persist. And it's very important to continue to educate the patients as well, because it can be a long haul, the treatment itself, and can be frustrating. So persistence and, of course, dedication at the end of the day is the key. Any questions from the floor?
This germinoma into germ cell tumors.
Right. So this germinoma is also one of the germ cell tumor, and we do treat it like that, although their responses are a bit different than the embryonal carcinoma or those. I have many of the ovarian dysgerminomas, but they also respond more or less similar. We can cure it. If it is in female, surgery is the first line treatment. If it is male, it's a chemotherapy to start with, and then surgery. But they do behave very well, and they do well in terms of the cure.
Thank you very much for a wonderful talk. I don't treat germ cell tumors, but I often get involved in case of metastatic presentation to the brain. In terms of choriocarcinoma, because they are so hemorrhagic, and if we don't have neurosurgical expertise, what do you do in your center with high burden intracranial disease with low burden extracranial disease? Do you treat them first with chemotherapy? Does it penetrate the brain or treat intracranial disease? Or do you ask the surgeons to take it out and then you start chemotherapy? Or SRS is another option. So what do you do in your center?
It's a very good question, actually, and it's one of the most challenging when it happens in the brain. And I'll give you an example of one of my patients, actually. I have so many stories, but with time, I couldn't tell you. I had a very young patient, 19-year-old, who had intracranial, intra-arterial metastases. It was choriocarcinoma, no disease anywhere else. So it can bleed. If you leave it, it will go through the vessel, artery will bleed. If you treat it, it will bleed. So in both cases, patient die. So I had a very long discussion with the patient, with the multidisciplinary team. In the end, the surgeon said, we cannot operate it because it will bleed. So I said, I'll give you the low dose chemotherapy, hoping that the shrinking will be very slow and we'll have time for the vessel to heal. At the same time, we asked the surgeon to be on standby if anything happened. They said, we are ready anytime, 24 hours, send the patient, we'll open at that time if bleeding starts. So I started with chemotherapy, 2 doses, 3rd dose, patient bled severely, significantly. They opened, unfortunately, we could not helped this patient. Patient survived, did not survive, and he passed away. So the treatment for that is for any germ cell tumor, including this one, not surgery, chemotherapy actually. Surgery role is later on if you have residual disease, and including in the brain, if you can. But with the highly vascular tumor, the risk of bleeding is too high. So try to be extra careful when we are giving the low dose EP. I even go further low dose EP with even in the low dose, I become 50% down when it happens in the brain, because these are highly vascular, and especially after seeing this patient dying, I am more careful. But these things happen. The only thing we can do is we just give a very slow dose rather than giving every 72 hours. I give it once a week in these patients. They still respond.
Thank you, Dr. Faisal, for a nice presentation. I have also got some patients who were treated, and two of them, they had recurrence, one after 5 years and the other after 10 years. So in such cases, what's your opinion regarding the use of liposomal cisplatin and the second-line chemotherapy, gemcitabine and ifosfamide combination? Your experience, please.
Thank you very much. Yes. So that is why I don't discharge the germ cell tumor also. I see them at least once a year, once they are above certain years. So they don't need to be followed up more closely, but once a year follow-up is usually important. So second-line chemotherapy, yes, gemcitabine is active, ifosfamide is active, cisplatin is active, oxaliplatin is active. You can give single agent, you can give combination, you can give 3 agents, depending how your patient is, how they can tolerate. I have given one patient 8 lines of treatment. Every time I was curing them, and he was relapsing it. So you can carry on with the chemotherapy. These patients are young patients, they can tolerate, you can give. So I am quite right. As we do not have many trials in what combination give chemotherapy, but we know the evidence which drugs are given and are effective. So you can, yes, you can give gem with cisplatin, gem with oxaliplatin, gemcitabine by itself, oxaliplatin by itself, cisplatin with any combination. And most of the patients will respond.
Thank you.
Thank you very much for an excellent presentation, especially this growing teratoma syndrome. It's a challenge for us here because we see quite a very, very bulky disease in the retroperitoneum. And obviously, development of secondary cancers in the teratoma, which presents with late secondary cancers, is a challenge. And that is why we always try to get a retroperitoneal lymph node dissection done. But my question to you is, when do you consider high-dose chemotherapy in patient with germ cell tumors? What are your indications in your center?
Yes.
For high-dose chemotherapy?
Thank you very much. That's a good question now, but it's a controversial thing actually. So those patients who did not achieve a full biochemical response, we give, and those patients who still have a residual disease after chemotherapy, you're trying to cure. So high-dose chemotherapy is usually given before the stem cell transplant. So we give them induction chemotherapy with a high-dose chemotherapy, and then we ask our transplant team, the stem cell transplant team, if they could do it. In my experience with stem cell transplant in testicular cancer is not very good, to be honest. Still, we are struggling. Is it the right approach to do the stem cell transplant, high-dose chemotherapy stem cell transplant? I do not think so, because at least in my experience, we have our transplant center is one of the biggest in the country, second biggest after King Faisal in Riyadh. We have the biggest number. So it's not the volume wise, we are doing very well. With our experience with specifically with the germ cell tumor is not very good. And if you look at the literature also, there are a lot of evidence, they even do not recommend it. They recommend to carry on with chemotherapy and surgery rather than doing stem cell transplant, because the evidence for stem cell transplant is early phase studies rather than phase 3 studies. So that's why it is a bit controversial, but people are doing it. They claim that it can cure the cancers. And so the question as yours was high dose chemotherapy. So we do use high dose chemotherapy if you are planning to give stem cell transplant, but so far not much success in our center or my experience.
But in which patients that you?
Yes. So those patients who have relapsed and those patients who have achieved complete biochemical response, their tumor marker have normalized and they still have disease in those patients.
Okay.
Thank you, Dr. Faisal, for very interesting cases. And at Shaukat Khanum Lahore, we do have quite a reasonable number of patients, and I would say 20 to 30% are like in poor risk group. And we do see quite a lot of complications. So my question is essentially regarding cisplatin use. For example, a patient gets a DVT or like a significant PE after a second cycle of chemotherapy, and I had a patient who had NSTEMI as well. So what is your approach in such kind of patients if someone gets these kind of toxicities while on cisplatin after 2 cycles and was planned for 4 cycles?
It's a very good question, actually. Either they developed or they had organ failure. So you can always give low dose cisplatin chemotherapy. The problem with the testicular cancer is carboplatin is not effective, it's not the any. If you really cannot give it cisplatin, then you have to move on to other non-platinum based chemotherapy like gem oxaliplatin is one of the very good combination, and I have very good experiences with it. So you can change it, but I try to push as much as I can in different combination. You have to sometime invent using different doses, like Sayed said, cisplatin, split dose cisplatin in bladder cancer if you cannot give full dose, and they are more or less as effective as full dose. Similarly here, I give only 20 milligram of cisplatin. Like the patient are presented with an EGFR of 35 only, I gave cisplatin. And most of the oncologists would not dare give cisplatin to somebody who has severe renal failure. But I do give it in a small dose, only 20 milligram. Usually does not do harm. It should be okay. You can help them with it. But if you think it is going to harm patient more, in that case, don't give cisplatin-based chemotherapy. Go to other platinum. Oxaliplatin is quite good. Gemcitabine oxaliplatin is very well known with very, very high response rates. And I've given it to quite a few patients with complete responses.
When you still online? If he is, I have a question for him.
That will be great. Yeah, that will be great. I think Dr. Shamim and Dr. Tunia both are still online.
He is online. I asked him. He said that you do somatic and germline tumor. Don't you? I am Professor Chima. I retired as chairman surgery from King Edward Medical University. You see, in 44 years, I've been following the genetic testing in the city. An expensive, difficult business. How does this germline genetic testing help you decide your management of metastatic prostate cancer?
Yeah, thank you, Dr. Chima. I think this is a very relevant question. Even Professor Hussain is here. We also face same problems within the NHS as well. We don't routinely recommend somatic and germline mutations as well, in contrast to in the USA, where actually they do for people even in the non-metastatic settings, if those who have a high grade or cribriform pattern or with a strong family history, we are not doing it routinely. But yes, when we are switching to the options of the second line therapy for MCRVC patients, then at that time we discuss in our MDTs meetings if particular patient will benefit from PARP inhibitors if they have any actionable mutations.
Thank you. Just a comment on Faisal. He started his lecture by saying, I know you are tired. When we don't get tired in the hall at 12 o'clock.
Professor Shamim Khan, yes, you want to make a comment?
Wanted to ask Dr. Faisal Azam, does he work in isolation or does he work with the urology team? Because, I couldn't understand the rationale of doing orchidectomy in the first patient he presented who has got widespread metastatic disease. So why did they decide to do an orchidectomy? I think in these patients, it is very important that you have multidisciplinary team setting so that you are working in close collaboration rather than in isolation.
Thank you very much for the question. No, we have a very big team actually. One of the biggest team, urology team, and we have very active MDT who decide about all the patient we treat. It's not in the isolation. We have one of the biggest cancer center in the country, not one of the biggest. It is the biggest in the whole of kingdom actually. So, and the biggest cancers we are treating is breast, GU. These are two biggest cancer we are treating. So no, we have the reason we were doing it because he had complete response, complete biochemical response. With non-seminoma, we are very aggressive, and the surgeons sitting with us, they're extremely aggressive, and I really appreciate them actually, because this is the way to a cure. Orchidectomy plus metastatectomy, retroperitoneal lymph node direction, metastatectomy in the lungs. Even if it is liver, we resect the liver, spleen. So kidneys sometimes are resected. They are extremely aggressive, and that is the reason our patient, we were looking at data, our patient cure rate is extremely high. And it's not only chemotherapy, actually. We start with chemotherapy, of course. But the surgeons are helping us a lot, to be honest, in these sort of patient. Unfortunately, our patient was a bit different. He was running away from the surgery. He agreed initially.
That's precisely my reason for my question. If your
Exactly.
patient is not listening to your advice and he doesn't want RPLND, which is the key treatment for him,
True.
why do orchidectomy on such a patient? This is for the education of young urologists in the audience. And if you have
Yes.
widespread metastatic disease, I think better refer the patient to oncologist. And you do orchidectomy as a part of RPLND, not in isolation, because there's no point in getting histology in a testicular cancer if there's a small tumor in the testicle, but you are leaving the rest of the tumor, or even no tumor, but maybe mature teratoma in the retroperitoneum. So that's what my point of asking you this particular question.
True. Actually, so it's the same urology team who did the orchidectomy when he agreed. And the plan was you'll have orchidectomy followed by retroperitoneal lymph node dissection and the lung metastatectomy. But the thoracic surgeon said the metastatectomy we can observe because they are too small. It's the patient later on changed his mind and he refused the retroperitoneal lymph node dissection, and we kept on trying to convince him. But this is what I'm saying. This is the challenge. What you are saying is the challenge, how to convince these young children to go through it. They agreed to one surgery, but did not agree it. So can we ignore these patients? No, we still have responsibility to keep on working with them. But that's why I presented actually with all these challenges.
Thank you very much. Thank you very much. Yeah. Any questions for my talk? If somebody wants to ask about robotic cystectomy, I'm here before I disappear. Yeah.
My question is, how could you give chemotherapy without having a tissue diagnosis? I think they did orchidectomy to get a tissue diagnosis.
No, actually, it was in testicular cancer, we can give chemotherapy without tissue diagnosis, but in our patient, we did a tissue diagnosis before orchidectomy was done actually. I think.
Any more questions from the floor, Professor?
About your case presentation, I agree with the approach of SPRD, since the patient is resting on dialytomide, would you not consider changing systemic treatment as well as this still drug is not working?
Is this questions to me?
Yes.
Can you repeat it? Sorry.
The question was, that
Volume.
first you opted for SPRT inhibition in metastatic cancer because of darolutamide. So, would you not consider changing to darolutamide as well in addition to giving SPRT?
Yeah, so that's a good question. So if patient is on darolutamide in this particular poll patient, because there was no evidence of disease on the conventional imaging, but there was some uptake in the prostate gland and no other site of disease. So in these patients, I'm not in a rush to treat with the systemic therapies. Already they are receiving their androgen deprivation therapy. These are the patients, subset of patients which may benefit from the local radiotherapy. If you want to delay your systemic treatment, because this Arto was a small trial, these patients gonna fail in a few months' time, and later on you can discuss with them.
Question. In this regard to when patient progresses on prostaxin, for example, would you use cabazitaxel as second line, or would you like to go on abiraterone and enzalutamide and then cabazitaxel?
Yeah, post docetaxel, yes. So yeah, we always tend to give ARPIs, isn't it? But however, the data says if patients actually, just to avoid the chemotherapy-related toxicity, it's not a simple actually tick mark. So I think in the clinic we have to discuss with the patients. Actually, we give them options, what they really want. Okay, and however, actually, if you see the results of a Tropic and CAR trial, cabazitaxel overall was better than ARPIs, but although it has its own side effects. And obviously, so I think it is, you can, in a simple answer, but again, I think it is better if we can discuss with the patients. We give them a second line options and let them choose and let them decide.
So how do you prepare your body for the
This question is to me again?
Professor Shamim.
Oh, okay.
I don't have a question. Sorry, I'm just going to take my hand down. Yeah. Thank you. Yes.
So my question was, in your video we saw that you did not flush the conduit. So how do you prepare your bowel prior to this radical cystectomy? And if you don't flush the conduit, what is the incidence of urinary tract infection in your substance post-operative?
Sorry, could you repeat the question? Sorry? Could you speak near the mic so that I can hear better, yeah?
The question, Prof, is that the ileal conduit wasn't flushed prior to reconstruction.
Actually, we all had the same anxiety when we started doing intracorporeal surgery. But even if when we do the orthotopic bladder robotic assisted, we just try to clean up with the swabs, but not really wash it or anything like that. We have not seen any incidents of increased, for example, infection, etc., by not flushing the ileal conduit. So this is rather strange, but of course, in open surgery, you try to avoid this contamination. But in robotic surgery, the contamination is minimal because what you are doing, once we open the bowel, you just suck it out. You don't allow the spillage of the bowel contents intraperitoneally, but we haven't seen any increased incidence of infection post-op just because we haven't flushed the ileal conduit.
Thank you very much, everyone. I would like to thank all our eminent speakers. It's been a very interesting and interactive session. And my apologies for running late. Thank you so much, one and all. We would very much hope that we would see you in future back in Lahore at Shaukat Khanum, Lahore and Peshawar at future Shaukat Khanum symposiums. Thank you.
I'd truly love to visit Pakistan. I hope soon one day. So I'm the past president of our society and current surgical education and training. Okay.
So good afternoon, ladies and gentlemen, and I welcome you all in this session of Uro Oncology Neurosurgery. And I have a privilege of introducing Dr. Kamran Hussain, who's the chair of this session, sitting beside me, and Dr. Irfan Yusuf, who's a co-chair sitting over there. We have 3 speakers for this session today, and all of them are virtual. They have sent us their pre-recorded talks, so we are going to play the talks first, and we'll take the question answer session at the end. Our speakers are with us online, and they will listen to your questions and respond back accordingly. So without further ado, I would like to start our session by first pre-recorded talk by Dr. Sarah Olson on Gamma Knife and how it has changed my thinking for meningiomas and metastases with preoperative irradiation. Associate Professor Dr. Sarah Olson is a fellow of Royal Australasian College of Surgeons, trained in Brisbane, Auckland, and Victoria. She works at Mater Private Hospital, Brisbane, and Princess Alexandra Hospital, Brisbane. Dr. Olson is an ex-chair of Neurological Society of Australasia and currently holding the position of chair of Board of Neurosurgery at Royal Australasian College of Surgeons. Her special interests include neuro-oncology, pituitary tumor, endoscopic surgery, trigeminal neuralgia, and functional neurosurgery. I welcome Dr. Olson, who is with us virtually.
Okay. Thank you very much for asking me to talk about how working in a gamma knife unit has changed the way I treat patients presenting to neurosurgery. I'm very sorry not to be there in person. I would really, truly love to visit Pakistan. I hope soon one day. So I'm the past president of our society and current surgical education and training board chair for neurosurgery. So I'm an oncological pituitary and functional neurosurgeon who dabbles in pain. Unfortunately, I have no disclosures. So what has changed for me? Well, I'll talk about the ones in green: meningioma, preoperative irradiation, and the need to be able to effectively treat radionecrosis and radioresistant tumors. So this is our gamma knife data. As you can see, we've treated over 4,000 patients. We have the gamma knife icon, which enables us to fractionate in 3 to 5 fractions normally, larger lesions. But when we really need the accuracy, that's when we're using the frame. So that would be for functional and neurosurgery, and for benign stuff, often in vascular stuff. So with meningiomas, who do we treat and who do we observe? Patients are honestly telling us at the moment how they will be treated. They get on their forums and they're not much interested in the paternalistic view of medicine, which we all have to work through. And all the while we're thinking this is a benign disease. Most surgeons feel, with the risk of surgery, that observation is reasonable, despite the fact most of them will grow. However, the advent of gamma knife and a less invasive procedure with less morbidity means some people are treating meningiomas up front. We still treat them when they grow. So the big pros of using gamma knife is you can drive straight away. It's a big thing for patients. Less risk. You can return to normal functioning immediately, and you're more likely to return to work than after surgery. And I would say also you are less likely to adopt the sick role that we see often after craniotomy patients. So I've blatantly stolen this slide, but one of the big cons is you've got no histology, and this is what's coming. Unless we get the answer from circulating DNA, we're missing out on a lot of information that will potentially guide our therapy. So particularly the methylation family and chromosomal losses, not so much the WHO grade 1, 2, or 3. And of course, with radiation, the mass remains. It doesn't magically disappear. You'd be lucky if they shrink by a quarter. And radionecrosis. As I'm a surgeon, I'll talk about the negative first. So this is a patient of mine, treated pretty standardly, skull-based tumor, good one for radiosurgery. But got this, she was remarkably well. She's still able to work. But, you know, she was treated 5 years ago and she's still got this. And she has a constant feeling of tinnitus. Radionecrosis is a real thing, and we don't always understand it. She did have a bit of perilesional edema before treatment, which I'll come to as a risk factor. It can occur at a median of 11 months after gamma knife. Mostly it's transient. It's occurs in 15% variably and can have some temporary and permanent morbidity rates. If you've got pre-treatment edema, and if it's on the convexity, you're more at risk of it. But this is good, of course, because the ones on the convexity are more easily treated with surgery. And that's the beauty of being a surgeon and working in gamma knife. So Avastin and laser are options for radionecrosis now, and giving us a lot more options than we've had in the past. With the posterior fossa tumors, excellent control. It's not as good on the convexity or parafalci. Excellent, as I said, in the skull base for tumor control. One of the first things I learned was not taking that last little bit, because that's where all the risk is. You want to, you love your microsurgery, and that's where all your skills are going to be tested, and you can see it right in front of you, tempting you. But really, there's similar tumor control between aggressive surgery and stereotactic salvage, so it's a little hard to justify. What about those really big lesions? Well, I thought they'd always come to surgery. No, not necessarily. And particularly in an older group, I think you might think about radiation. That's got pretty good chance of, with hypofractionation, say 3 to 5 fractions controlling the size. And 66% who were symptomatic had an improvement or amelioration of their symptoms. Complications were more on the convexity, as I've said, but that's okay because they're easily treated with surgery. As I said, you'd be lucky if it reduces by 25% in size. Just a case to think about. This is a guy who presented who had no neurology other than his symptomatic hydrocephalus, no cranial nerve deficits, nothing to suggest there was pressure, which there was, from this enormous clival meningioma. So the decision made at the skull base in multidisciplinary meeting was to debulk it and proceed with radiation. He had complete neurophysiology monitoring through the procedure, and it was debulked. But the impression on the brainstem after surgery was actually a little worse on this post-operative MRI. We might expect that while we're waiting for this to settle down. He was hemiplegic at that point and required a tracheostomy, and was starting to recover when he died from a pulmonary embolism. So I guess that case really got me thinking about, particularly if this man had been older, he was 54, whether, perhaps, a fractionated radiation might have been an option. So this is a patient of mine. She has MS, a limited cerebral reserve. The convexity one responds well to surgery, not to radiosurgery, so I took it out. The one on the bottom left is more skull-based, tentorial. As I said, she's got limited cerebral reserve. Skull-based ones will do well with radiosurgery, so we treated it with radiosurgery. This girl is a very bright PhD student in her 30s with a growing meningioma, and I thought if she was my daughter, I would go with radiation. And so we did, and it's been controlled. This lady is a single mother, cannot afford not to be working or to lose her license. It's a growing lesion. We can say, oh, look, we can wait maybe till the kids grow up and take it out, but we're not going to get that bit on the sagittal sinus, or we can treat it while it's small, which is preferable with gamma knife, which is what we did. This lesion, which I got a lot of flack for at our conference, a lot of the surgeons felt this should come out. So this was a person in their late 50s with this meningioma and trigeminal neuropathic pain. I felt that if it was me, and I'm 52, that I would have radiosurgery. And after discussion with the patient, that is what we did, and their trigeminal neuropathic pain got better. If it hadn't, I would have done a balloon compression. This lady I was quite concerned about. She had a rapidly progressive cavernous sinus syndrome, and I felt she came from northern Queensland, which you could often see squamous cell invasion. We might need to do a biopsy, but instead we did a dose-to-day PET, and that can be very helpful in defining what is meningioma. And she got all her symptoms resolved, and she was very happy. This lady, a history of metastatic breast cancer. Normally this would make us anxious, but it's a meningioma. Same with this lady, funny looking lesion, was a meningioma, but it was atypical and did grow quite significantly in the 6-month scan, so I took it out. This one, I'm pretty sure the radiation doctors won't want anytime soon. And these are really in no man's land, but very easy for surgeons. It's actually remarkably easy to just take that lateral wall of the orbit out, open the periorbiter and remove the tumor and sew it up. I think the whole thing took me maybe 2.5 hours. It's very straightforward. So I think that gamma knife's got excellent control of meningiomas, particularly the skull base. We've treated 242 meningiomas since starting at our hospital. And larger lesions, I think I've got to get my head around about where we look at surgery and where we look at hyperfractionation with radiation. My next topic is preoperative irradiation for brain metastases. I have to say, Rev did all the work here. I was just the willing surgeon. As soon as I heard that 20% of my patients were not receiving postoperative radiation for various reasons, I was sold, and I love the efficiency of it. So there are issues with postoperative radiation. The cavity is not an easy target as opposed to preoperatively when you've got a nice clean target. There can be logistics problems and delays in initiation of systemic therapy and postoperative recovery getting to their radiation. An alternative was to do it preoperatively. Another reason is that there is a significant reduction in the literature in leptomeningeal disease and radionecrosis. So the patients would come in, they would have their radiosurgery, have surgery within 48 hours and have an MRI within 48 hours. So in the prospective first group, there are 24 patients with 25 brain metastases. And as you can see, they were treated in a fairly standard way. There was no radionecrosis, 1 patient with leptomeningeal disease, 92% local control, and 100% local completion rate, which we've never had before. Interval between radiosurgery and surgery was 1 day. Median length of stay in hospital was 3 days. And the interval between radiosurgery and surgery and systemic therapy was 22 days. So if we compare that to the literature, our local control preoperatively is 92% versus 72% for postoperative radiation. Radionecrosis in was 0% as opposed to nearly 1 in 5 for postoperative. Leptomeningeal disease, much reduced. Local completion rate, 100%. It turns out everywhere else in the world also has a problem getting their patients to postoperative irradiation. So this is a big thing, I think, that they complete their local treatment. And the interval between radiosurgery and surgery was 1 day compared to 27 days in the literature, and half the time in getting to radiosurgery and surgery to systemic therapy, which I think is outstanding. So for me, that has become the standard of care for my metastatic patients. So we've now at our public hospital treated 41 patients. In the retrospective cohort, we found exactly the same. We're also treating a large number through the private hospital. And here's another personal reason of my own. I received this via text to say that I had put the pin in the top of the bone plate. So if we do it preoperatively, there won't be a bone plate. Coming now to laser, well, our laser's been a really important addition because I needed a way of treating radionecrosis or tumours that have failed radiation. And there's actually been a position statement on laser. It's that laser has a short recovery time, low rates of rehospitalisation, expedited wound healing, and the potential to receive adjuvant treatments sooner. There is a consensus that LIT should be considered in patients with recurrent or progressive malignant tumour inaccessible to surgery, or where the patient can't tolerate surgery. And laser is a treatment option for relapsed brain metastases, and it is a really good option for radionecrosis. It seems that up to 100% control of radionecrosis. So a long, thin target is ideal because with one laser catheter, you can only really get 2.5 centimetres wide. And these are about 16,000 Australian dollars, so about maybe 10,000 US. And our hospitals are really keen that we only use one. So the small lesions are best, but you can create a cylinder by pulling the laser back. So it's indicated glioma, metastasis, radionecrosis, epilepsy, and pediatrics. With pediatrics, for hypothalamic hematoma, a great indication, or in patients where they're very young and you're trying to avoid giving them radiation, that this may be an option until the brain develops further. So glioma, deep-seated lesions, patients who can't tolerate open resection and perhaps resistant to all other therapy. Interestingly, a comparison of patients undergoing biopsy and chemorads shows comparative survival to those undergoing biopsy and LIT. We'll have to watch where that lands. It may be that we can keep radiation and chemo up our sleeve if this is the case, but we'll have to see how that develops. Treated with LIT, the survival time and recurrent GBM was similar to lomustine and Avastin, but much less morbidity. This is a patient of mine who is on Xarelto and can't tolerate Avastin. He's really struggling. He's a very fit 84-year-old. This is the lesion here. As you can see, it's nice and long and thin. I can certainly access that down the long axis. So here's my case coming up in a couple of weeks. This is myself and Saad. With our first case, we used the Medtronic robot to get it into position. This tiny little screw, a lot relies on this plastic screw. If that veers from the trajectory, you will be completely off. So that screws through a tiny little hole in the skull. Then we measure out the laser fiber, and it's housed in this plastic sheathing that enables the water to roll through each side and irrigate and cool the laser down. So this is us. If you have an intraoperative MRI, it would be definitely a good idea to utilise it. For us, we've got to transfer the patient to MRI, and any movement in that laser catheter would result in not being able to proceed. So this is our first case. And here was a case I could have resected it, but I wanted to try a laser in a straight forward position first. And so I took the front one out to put laser for the last one. His wife, I could not tolerate him on steroids, and he couldn't manage without them. I'm pleased to say he's been off them and doing extremely well now. This lady was on a 4th generation ALK inhibitor, had progression of the posterior lesion after radiosurgery. I treated her with LIT. I didn't get complete coverage, which is interesting, really, because I really wouldn't have thought she'd had such a dramatic response. So this is over a year later. Even though I didn't get complete coverage, and the biopsy came back as tumour. And this is her in the paper. She was hemiparetic. She's off steroids, no Avastin, doing well. This one had metastatic breast cancer. I've known since 2019, had preoperative irradiation to the motor strip lesion and partial resection with MEP monitoring. Unfortunately, it came back and I caught up with her quite late. And I was horrified to see a lady I did not recognize. This is what the steroids had done to her. We've all seen patients like this. It was a big mission to get her to surgery to treat this, but she did very well for a period and came back to see me. We got her steroids down. And then, of course, pride comes before a fall. But I'd been to our latest meeting and I knew that she could have consolidation radiation because a laser would deal with the radionecrosis. And that's what we've done. And she has been doing brilliantly well and continues to do brilliantly well and has not had any further radionecrosis. So treatment for radionecrosis, they do fantastically well. They can get off their steroids within 13 days normally. Other treatments have a lot of side effects, as we all know. And if you look at this, if you're using Avastin, it stops working really by about month 6. The lesional volume goes up, whereas a LIT, it goes up initially after treatment, then continues to get smaller. And now we're looking at consolidation radiation, where patients have further radiation after their laser. And that seems to be getting a local control rate of 100% with no radionecrosis, interestingly. So we don't need to be so worried about radionecrosis. That seems to be the real thing that LIT is fantastic for, is radionecrosis. And so that means we can up-treat with our radiation. So if you look at this one, this is biopsy-proven recurrent Mets. This group had laser plus further radiation. They do very, very well. This group had laser alone, and this group just further radiosurgery. So really a big benefit in doing the pair, and those treated with radiosurgery alone had a 25 incidence of radionecrosis, percent incidence. So I think that it is an important new therapy laser, and I think that it's really, really good at radionecrosis. And so that means we can up-treat with our radiation and get better control for our patients. If you've got an intraoperative MRI, this is a great time to use it. As it's the newest treatment, we haven't CGA approval in Australia. That's probably my biggest headache, is getting it past health funds and Medicare. Thank you. This is just our team, which has grown quite a lot since now. Sar joined us for a year. Thank you.
Thanks, Sarah. Thanks for a very exciting talk. And most importantly, it was very relevant to our setup where we work. So with this, I'll move on to the next speaker. We will take questions from you, Sarah. Just stay with us. So our next talk is now on awake surgery for low-grade glioma by Professor Hugh Defoe. So Professor Defoe is the chairman of neurosurgery department at the Montpellier University Medical Center and head of the INSERM 1191 team, plasticity of the central nervous system, human stem cells, and glial tumors at the Institute of Functional Genomics of Montpellier, France. He's an expert in the awake cognitive neurosurgery for low-grade gliomas. For his innovative work in the neurosurgery and neurosciences, he was awarded Dr. Honoris Causa 6 times, and he was the youngest recipient of the prestigious Herbert Olivecrona Award, which is a Nobel Prize of Neurosurgery for from the Karolinska Institute in Stockholm. He has written 5 books and has over 495 publications in the international journal, ranging from neurosurgery, Uro Oncology to fundamental in neurosciences, including cognitive sciences and brain plasticity, for a total of more than 40,000 citations with an H index of 111. He gave more than 690 invited lectures and was invited as a visiting professor in more than 60 institutes. So let's hear from our expert today.
Dear colleagues, thank you very much for giving me the opportunity to share my experience regarding language and cognitive mapping and monitoring in low-grade glioma surgery, about over 1,000 awake procedures. With 25 years of experience based on early maximal connectome-based surgery, we changed radically the natural history of the disease by increasing the overall survival over 17 years and by preserving the quality of life of diffuse low-grade glioma patients, namely less than 1% of severe permanent deficit. When I started 2 decades ago, the survival in this kind of low-grade glioma was around 6 to 7 years. In the French low-grade glioma consortium, we published a paper already 7 years ago, a prospective study demonstrating that we reached survival around 15 years thanks to early and maximal resation. More recently, with my colleague Luc Taillandier in Nancy, we published survival over 16 years, but also with preservation of quality of life, namely a Karnofsky status at least 80 over 12 years. In a recent paper, we also demonstrated that when we do an extensive neuropsychological examination before any treatment in patients with low-grade glioma diagnosis, in over 55% of them, they already experienced language, episodic memory, attention, executive functions, personality, and so on deficit. So demonstrated that the patients are not so well. These deficits are related to the invasion of the white matter tract connectivity. For example, invasion of the superior longitudinal fasciculus related to executive dysfunction, or an invasion of the arcuate fasciculus in the so-called right non-dominant hemisphere and mentalizing deficits, and so on. This is the reason why we propose to do a surgery up to functional boundaries, considering both cortical and subcortical critical networks, namely to adapt the resection according to the individual functional anatomy. This is possible only if we accept definitely that localizationism does not exist in the brain. We have to move toward a connectomic account of brain processing and to become neuroscientists in order to better understand mechanisms of neuroplasticity. Even if functional imaging can be helpful, we have nonetheless to understand that there is no reliability at the individual level because fMRI is not able to make the difference between critical versus compensable structures, and that DTI tractography is not the function, but just a reflect of the anatomy. This is the reason why we decided since 25 years ago to do a systematic awake surgery in order to benefit from cortical and subcortical mapping using intraoperative electrical stimulation and by doing online anatomofunctional correlation. So how I do it means that before any surgery, I will save time to better understand what are the needs of each patient according to his or her job, hobby, habits, leisures, lifestyle, and so on. Therefore, into the operating theater, I will do a mapping à la carte according to the wishes of the patient, but also according to the connectivity in order to preserve the projection fibers and the association fibers, which are definitely the limitation of neuroplastic mechanisms. In other words, into the operating theater, my philosophy is to remove as much as I can a part of the brain invaded by chronic tumoral disease according to functional cortical and subcortical boundaries identified in real time thanks to cognitive monitoring. So I will not use technology, no neural navigation, no DTI, no fMRI, no intraoperative MRI, no microscope, no ECOG, and you will see that you can nonetheless achieve 99% of good results. I do not understand why the vast majority of neurosurgeons now the habit to do awake surgery in the so-called left dominant hemisphere for language mapping and to continue to achieve resection under general anesthesia in the so-called right non-dominant hemisphere. Indeed, this right hemisphere is critical for so many functions in order to continue to enjoy perfect normal life, especially complex movement, spatial cognition, critical for driving, social cognition, critical for relationships between human beings, non-verbal semantics, executive functions, but also emotion, personality. Indeed, we recently reported by achieving postoperative cognitive assessment that at least 20% of patients still experience a deficit regarding a cognitive function, especially regarding executive functions such as working memory or mental flexibility. Indeed, it's definitely possible to incorporate further tasks like dual task or to ask the patient to name the item which was presented previously in order to monitor this higher order cognitive function. To give a little bit more detail, we published atlases, not only regarding the cortex, but also the white matter tracts of networks involved in the control of complex movement, especially regarding the bimanual coordination, which is definitely very important if you would like to play sport or to play piano or to be a surgeon. In the right non-dominant hemisphere, we demonstrated that it could be very helpful to incorporate the line bisection task, especially at the white matter tract mapping level, in order to identify the part 2 of the superior longitudinal fasciculus and to avoid any permanent hemi-neglect. More recently, we published in Nature Communications an extension of the previous study by giving new insights into the frontoparietal medial network involved in visuospatial attention, which should be preserved during surgery. We demonstrated that Broca's area does not exist, and if there is an output for speech, it is located within the ventral premotor cortex. So we have to better consider networks underpinning different subfunctions, especially for language. The connectome-based surgical resection principle relies on the fact that whatever the lobar location of the tumor, for instance, in the so-called Broca's area or a left parietal area or a left temporal region, in all cases, we will be into the contact of the connectivity at the end of the resection, namely in this example, into the contact of the dorsal arcuate fasciculus underpinning the phonological pathway. Of note, we have recently demonstrated that the anatomy of the arcuate fasciculus was not yet perfectly understood, especially because the vast majority of temporal cortical termination are not at the level of the so-called Wernicke's area, but at the level of the middle and inferior temporal gyrus. There is also a very important ventral semantic pathway underpinned by the inferior frontooccipital fasciculus, and when we stimulate it into the operating theater, we will induce semantic paraphasia. We also demonstrated that it was absolutely critical to preserve the left inferior longitudinal fasciculus, more basally located, otherwise we could induce difficulties regarding the lexical access. In practice, when there is an increase of the reaction time for naming, then the patient can have difficulties to return to work. It's very important to know that the right inferior frontooccipital fasciculus is critical for this non-verbal semantic processing. Even more recently, we already demonstrated by doing a very extensive evaluation of the behavior following surgery that a subset of patients still experienced some degrees of personality and behavioral modification following resection, especially regarding irritability, hypoactivity, disinterest, so with some possible negative impact on the quality of life. It's also possible to ask patients to recognize emotion expressed by faces into the operating theater in order to monitor the so-called mentalizing, namely the theory of mind, which is absolutely critical for empathy and then for relationships between human beings. The most important part, namely the results about 870 diffuse low-grade glioma operated on in so-called eloquent areas, such as the frontal area, the Wernicke's area, the Rolandic system, the corpus callosum, and so on. We recently published this series in Uro Oncology, demonstrating that the mortality was zero, with less than 0.5% of severe permanent diaphysis. In addition, 85% of patients preserved their cognition, but also with 10% of them who improved their cognition following a postoperative cognitive rehabilitation. Very importantly, 94% of them returned to work with an impact on epilepsy in 80% of patients. Regarding my own series, median survival is above 17 years. This is very important in order to increase the extent of resection by doing another resection a few years later, thanks to mechanisms of neuroplasticity which occurred in the meantime. For instance, in this example, I left voluntarily during the first resection the so-called knob of the hand, which was finally compensated 5 years later, allowing to remove this area in a patient enjoying a perfect normal life 3 months following surgery. Of note, beyond the need to preserve the intra-hemispheric connectivity, we started to understand the role of the inter-hemispheric connectivity, typically when we induce a transitory supplementary motor area syndrome. We know now that the patient will recover thanks to a re-increase of the connectivity between hemispheres. Recently, we published a paper demonstrating that it was possible not only to use plasticity between a first and a second surgery, but also between a second and a third surgery, allowing to increase the extent of resection in diffuse low-grade glioma patients while preserving the quality of life. This allowed to reach a median survival almost 18 years. We also demonstrated that because this is a diffuse glioma, if it could be possible to do a supratutorization, namely beyond the flare abnormality visible on the preoperative MRI, then we can change radically the natural story of the disease with 16 years of follow-up by preventing malignant transformation and then death. In order to increase the rate of supratotal resection, we propose to arrive earlier by doing surgery in incidental diffuse low-grade glioma. And we recently reported a multi-center experience with Udine, Calgary, and UCSF showing 93% of survival after 10 years. We also published in incidental low-grade glioma that 97% of patients return to an active life, including working full-time. To help younger people, we published Atlas of neuroplasticity in the MNI template, so giving them the opportunity to predict before surgery if the patient will recover or not according to the extent of resection, especially within the white matter tracts. Knowing the limitation of neuroplasticity, especially the white matter tract, is very important not only for neurosurgeons, but also for medical neuro-oncologists and especially radiotherapists in order to preserve the quality of life and to adapt the treatment according to the better understanding of the connectivity at the individual level. This is the reason why we reported in neuro-oncology modification of the paradigm of management of low-grade glioma patient by trying to push the resection earlier, to reoperate the patient, and finally to postpone adjuvant treatment, especially radiotherapy, to preserve not only the quality of life, but also to increase the median survival. Indeed, remember that this multi-center study between Nancy and Montpellier demonstrated that the patient can live now over 16 years by preserving perfect quality of life. To achieve this kind of results, it's very important to be a neuroscientist, because we are neurosurgeons, and then to be able to propose new model of cognition in order to use them for the preoperative planning, but also into the operating theater. Once again, to help younger neurosurgeons, we recently published the sole atlas in the world literature about 16 functional domains regarding the critical networks with cortical hubs and white matter tracts, absolutely essential if we would like to preserve the quality of life of the patients. Now, the next step is to better understand interaction not only within, but also across networks, and especially between both hemispheres. In this state of mind, we developed the concept of meta-network brain, namely demonstrating that the brain is a perpetual succession of new equilibrium states and is not fixed, which is very important for the management of patients with glioma. Into the operating theater, this concept is very helpful because you can ask a patient to do two tasks simultaneously, to stimulate and to see that by disrupting some specific network, the patient is still able to move, is still able to talk, but is not able to continue to perform both tasks simultaneously. So the goal is really to do mapping and cognitive monitoring à la carte based on better understanding of the functional connectome at the individual level. And to this end, be careful to technology, because the risk for younger people is really addiction. And never this kind of information could be provided by the actual technology. So to conclude, beyond survival, even if, of course, we increased, as you have seen, the survival over 17 to 18 years, we have to preserve the quality of life of low-grade glioma patients, not only by avoiding to induce permanent hemiplegia and or aphasia, but also by preserving the higher order cognitive functions, such as the executive function, as well as the emotional processing, in order to allow the patient to return to normal life by preserving his behavior, his her personality, and then to be active for at least 15 to 20 years. So the goal is not just to remove a tumor with an oncological point of view, but first of all, to treat a patient as a human being by understanding the interactions between his or connectome and the natural history of the disease, which will be radically changed thanks to our management. Thank you very much for your attention.
Thank you very much, Dr. Defoe. Now we're going on to the next speaker. The next speaker is Dr. Rajiv Mangla. He is a US board certified radiologist in New York and is affiliated with the Upstate University Hospital. He has various fellowships in neuroradiology, advanced neuroimaging, and vascular and interventional radiology. He is a member of the American College of Neuroradiology and Radiological Sciences Society of North America. His interest and expertise lies in quantitative neuroimaging and diagnosis and follow-up of brain tumors, and advanced imaging and follow-up of brain tumors. He will be talking about neuroradiology, of course, as an ever-expanding field with its clinical relevances. Can we now play his pre-recorded talk, please? Thank you.
Good afternoon, everyone. My name is Rajiv Mangla. I'm Associate Professor of Radiology at SUNY Upstate Medical University. It is a great honor to speak in this prestigious meeting. I'm very thankful to the organizers for this kind invitation to speak on neuroradiology in brain tumors. I don't have any disclosures. We will cover imaging in brain tumors. We will not only cover the anatomical imaging, but we will cover some aspects of metabolic imaging, and the physiology of the brain tumors. We have a few objectives. We will cover radiology in grading of gliomas. We will emphasize on recurrence, pseudoprogression, pseudo-response, radiation necrosis, and identifying tumor recurrence. We will cover these modalities. Let's get started. This is a gentleman with a temporal lobe seizures. We did MR imaging, and there is T2 flare mismatch. As we know that T2 flare mismatch is quite suggestive of a IDH mutant glioma. And these I have a good prognosis. What about advanced imaging? We did advanced imaging. It indeed shows a very low perfusion. Low perfusion means that tumor has a good prognosis. And so everything was turned out to be a low-grade glioma. So another case, we have a non-enhancing tumor. We did advanced imaging. Advanced imaging was suggestive of a high-grade glioma because RCBV ratio as compared to the normal brain parenchyma was 3.5. And this turned out to be a high-grade glioma. This was an enhancing tumor, and we did MR perfusion imaging, and MR perfusion imaging showed a very low perfusion, and this turned out to be a pilocytic astrocytoma. Another patient, we have an enhancing lesion. We do some advanced imaging. We do spectroscopy, very high choline to creatine ratio. As we know, the high choline creatine ratio is quite suggestive of a malignant lesion, and but we don't know what kind of lesion is this. We do perfusion. Perfusion shows a high a high perfusion RCBV in the lesion, which is suggestive of a malignant lesion, but we still don't know what kind of, whether it's a GBM or a metastasis. We look more carefully in the peritumoral region. If we see this lesion, we have a peritumoral high CBV, which is suggestive of a peritumoral infiltration, and this lesion is suggestive of a glioblastoma, because we know that in cases of glioblastoma, there is infiltration, while in cases of metastasis, there is no infiltration. And we can do another criteria, which is also derived from the perfusion maps. These perfusion maps can show the recovery. Recovery in this case is suggestive of a glioblastoma. It's more than 66%, but not a overshoot. Now we have another patient. We do perfusion imaging. Perfusion is very high, suggestive of a malignancy. We do recovery maps. Recovery maps are suggestive of a metastasis because recovery is about 25%. This is 25% of the baseline, and this is suggestive of a metastasis. So this recovery is a very helpful, and it can be derived from the perfusion parameters, and we will see how we can be helpful in differentiating these brain tumors. So we can also study peritumoral region in these cases. There is no infiltration, which is also favoring the metastasis. So this is a metastasis. We can study peritumoral region on MR spectroscopy, and MR spectroscopy shows there is no peritumoral infiltration. Now, peritumor, in this patient, we have a peritumoral infiltration. As you see, there is increased choline in the peritumoral region. There is a decreased NAA, and there is a lipid lactate peak, which is extending into the peritumoral region. So increased choline and increased lipid lactates are the malignancy markers. So now we keep going, and we can see, like, by these maps that choline, this is choline, creatine, NA, choline ratio, choline to creatine ratio is increased. This is a normal brain, and this is the tumor in the peritumoral region. There is increase in the choline creatine ratio. Another patient, we have a enhancing tumor, and in the enhancing tumor, there is a high choline to creatine ratio. There is infiltration of the fibrous tracts, but we don't know whether it's a GBM or a MATS or a lymphoma. We do perfusion. Perfusion is very surprising to us. There is a, within this enhancing tumor, see the enhancing tumor here, there's a very big enhancing tumor. While we see the perfusion maps, the perfusion is very low. This is suggestive of a lymphoma, which is like, which is cerebral lymphoma, shows a enhancement perfusion mismatch. As we can see in another patient, that there is a enhancing lesion, but the perfusion is very low. This is called enhancement perfusion mismatch. This is called cerebral lymphoma. And we have another patient where we thought this is a cerebral lymphoma, but we did the perfusion imaging. Perfusion imaging did not show any enhancement perfusion mismatch as we saw in lymphoma. But rather it shows a high increased perfusion, which is suggestive of a glioblastoma. So we have two examples here. There is a mismatch where perfusion is low, which is suggestive of a lymphoma, and we have GBM where the perfusion is high, suggestive of a malignant neoangiogenesis. So perfusion depicts a neoangiogenesis in the brain tumors. So we have another patient, and we did not know what it is. We did diffusion and ADC maps, and we did perfusion. Perfusion shows somewhat enhancement perfusion mismatch, and we do the curves. The curves are very unusual type. It shows overshoot. If you see that there is no overshoot here, there is an overshoot here, and this overshoot is suggestive of a lesions called lymphoma, and we published it. There is a overshoot in these cases of lymphoma, as you see here, and in cases of GBM, their recovery is about 66%, more than 66%, while in cases of metastasis, the recovery is about less than 33%. So these recovery maps, they are nothing but perfusion maps, and we can these are in contrast going through so this recovery suggests the leakage, and the leakage is seen, as we know that in brain metastasis there is no blood-brain barrier, and that's why the recovery is low, and this is quite suggestive of metastasis. Lymphoma has overshoot, as we see here, So this is a very good information we can get. And this is a patient we did, the neurosurgeons did neurosurgery, and the area of diffusion restriction appeared. And this is very important, like, when we report these cases, because these can enhance. And so when this enhances, this means this is a subacute infarct. It is not a tumor progression. Please don't read this as a tumor progression. This is pseudo progression due to the infarct or ischemia due to surgery. So it is very important to recognize these infarcts on the post-operative imaging. So progression versus pseudo progression. Now we have changed the topic to progression versus pseudo progression. And as we know, pseudo progression is quite common after radiation and temozolomide. Actually, this is a good response to the treatment. This is edema and increase in enhancement. But perfusion, luckily, in these patients are low. So there's a perfusion gives us a good chance to so coming to the mechanism of pseudo progression, we know that these patients which has pseudo progression, they are like, showing a good response to the temozolomide. So that should not be called a pseudo progression. They should not be called a true progression. They are pseudo progression. So tumors are very high RCBV, and pseudo progression is low blood volume. So but there is a overlap between the two. So we have to be very careful when we are reading these MR perfusion. Here is one example. The perfusion is low in pseudo progression cases, and true progression cases show a very high perfusion. Another example, this is a post-op scan, and we do a follow-up scan after 3 months. We don't know what kind of disease is this. This is a progression or true pseudo progression. We do perfusion maps. Perfusion map shows a low RCBV, suggestive of a pseudo progression. We can also do spectroscopy in cases of pseudo progression. As we know, in glioma cases, there is an increase in choline to creatinine ratio, and same principle applies to the pseudo progression cases. We can create these maps these maps can be overlaid on the brain tumor maps, and these brain tumors can show increased enhancing tumor or decrease choline creatinine ratio. So depending on tumor progression versus pseudo progression, increased choline to creatinine ratio can be seen in cases of true progression. So true progression shows as a malignant glioma, high choline to creatinine ratio, as we saw in the original cases. So this is a patient with after 4-month follow-up, there is a new enhancing lesion, and we don't know this is a true progression or pseudo progression. We do multi-parametric imaging, and multi-parametric imaging we do perfusion and spectroscopy. Spectroscopy, as we know, the malignancy is denoted by choline, increased choline peak. In this patient has a increased choline peak and is suggestive of a increased choline to creatinine ratio, suggestive of recurrence, and their perfusion is very low. So this is just a summary to say that there is a increased choline to creatinine ratio and a high RCBV and a low ADC in cases of true progression. So pseudo progression is a clinical diagnosis, and it's a very challenging thing, and we have to be very careful when we are reading the scans after 3 months of the scan of the radiation and temozolomide. So another phenomena which is analogous to the pseudo progression is radiation necrosis. Only difference is pseudo progression occurs early, and so we don't call it early radiation necrosis, but we call it pseudo progression. But radiation necrosis occurs about 3 to 12 months after the treatment, and it is often seen with the chemotherapy and radiation combination. So what are the radiological patterns? In radiological patterns, we see the Swiss cheese pattern. We can see the soap bubble pattern, which is suggestive of a necrosis within the enhancing component. If I can convince you here, within the enhancing component, you can see small areas of necrosis. So these are called you can name it Swiss cheese, you can name it soap bubble, but the main thing is what we are looking in this enhancing component, the areas of necrosis within the enhancement, within the solid enhancement. This necrosis can be seen in the GBM, but this is the necrosis which we are talking about. We are seeing it as a necrosis, and so what favors recurrence? The ependymal enhancement. And we can do spectroscopy. Spectroscopy will show in recurrence cases will show a high choline to creatinine ratio. we can do perfusion. Perfusion will be low in cases of radiation necrosis. This is an example of perfusion imaging. As we can see here, the perfusion is low in this case. So we while in perfusion in the radiation necrosis cases, there will be high perfusion imaging. So here is another example. There is a new enhancement. We don't know what it is. We do multi-parametric imaging. We do spectroscopy as well as perfusion. This is a common trend we do these days. The CBV is low and there is no significant choline peak. The only dominant peak is the lipid and lactate, and these lipid lactate peak is suggestive of a radiation necrosis. So now moving forward, we don't can easily call it as a radiation necrosis. So now we are going for a new phenomena which is called as anti-angiogenic therapy. Anti-angiogenic therapy, as we know, leads to anti-VEGF and leads to decrease enhancement. So, but it does not mean that decrease enhancement tumor response. As we see in this example, this patient has decreased enhancement, but this is not certainly a true response. It can be a pseudo response, and the perfusion is high. And indeed, when we do further follow-up, the tumor has progressed. So we have to be very careful when the patient is on Avastin. There is a good chances of pseudo response. There is another example. The tumor is decreased, but there will be more infiltrative pattern in cases of Avastin. So, but the perfusion is relatively more helpful. This is another example where diffusion is helpful. So you will see there is many diffusion abnormalities in cases of patients on Avastin, and these are if there is a dark ADC, we will call it a good response, and if there is a not too dark ADC, there is a mild dark ADC or isodense ADC, we will call it a recurrence. So this is like, we did this study and we found that dark ADC is suggestive of a high survival in these patients. So this is on the basis of these pseudo progression and pseudo response, they changed the criteria to McDonald criteria to Reno criteria, and this taken into the account of pseudo progression as well as pseudo response. So these criteria led to Reno criteria, and pseudo response Reno criteria is like that we have to see not only decreased T2 enhancement, we have to see the decreased T2 flare imprint hyperintensity, and the dose of the corticosteroid should be decreased, and patient's clinical status. So pseudo response is very common after Avastin, and we have to be very careful. And similarly, like, we have modified criteria for, because now we have post radiotherapy scan as a baseline scan rather than post surgical scan. So that's a major change into the modified Reno criteria. So just a few words that pseudo progression, pseudo response has been taken in the Reno criteria. Now we have Reno 2 criteria, as we know. So these, other than Reno criteria, multi-parametric imaging can be helpful, and we do use it a lot for any question raised into the brain tumor boards, and we have found it useful. And they are now not only Reno criteria is on the glioma, we have Reno criteria with the immunotherapy, we have Reno criteria for low-grade glioma, we have pediatric Reno criteria. So more than Reno criteria, we in the radiology are more important is BT rads. As we know in mammography, there is a BI-RADS. This is a very good, very helpful, and I would encourage everyone to look into the BT rads criteria. I have found them useful, and they are like, very good in cases of deciding the or reporting the brain tumors. Please have a look on the BT rads criteria. And now I would change the topic to radiomics. This is, as we know, machine learning and deep learning are a very upcoming field. We can find out the texture analysis, like from that same T1, T2 weighted images, we can find so many characteristics, like, within the brain tumor, which can be read by the machine, And this machine learning algorithms has been very useful in cases of prognostic of markers for the glioblastoma. And they are adding information on simple MR images. Like, we from the MR images, we can calculate physiological microenvironment, which is concerned with the cell density and necrosis, depending on the T2, T1, and T1 post-contrast images. We can find out blood flow, cell density, necrosis, and edema. We can create a different combination of T2 and T1 signal, and we can create these habitat maps depending on in these 4 maps. So this we have created an additional sequence, which is like, more helpful. And these are like, machine learning things, and they can be helpful in reading the diagnosis and the prognosis of the tumor. These are cellularity maps, which can be converted by the radiomics. This radiomics can convert the area of cellularity depending on the ADC enhancement and T2 flare imaging. And similarly, we can calculate the angiogenesis maps. These angiogenesis maps are on the perfusion, and we can tell whether they are areas of high angiogenesis, low angiogenesis, and minimal angiogenesis. So tumor is different. These angiogenesis maps can subcategorize tumor into the angiogenesis, like, so this tumor has a quite significant area of voxels are high angiogenesis, so that's suggestive of a malignant tumor. So machine learning has a lot of information. A few words which is like, tumor infiltration is a new area, like, which machine learning is helping a lot. And with the help of machine learning, now these the multimodal imaging can find out where there will be tumor recurrence, and we can find out where there will be area of recurrence, so that we can predict which region will be more the tumor is infiltrating, and there could be possibility of giving high radiation in this area, so that there is no recurrence in this area. So based on radiomics, we can find out that tumor infiltration within the peritumoral region, and we can predict tumor recurrence, which is like, virtually impossible based on standard MRIs. So radiomics is playing a great role in diagnosing and follow-up of these brain tumors. I have given a very small synopsis. So radiomic features are becoming very, very important in cases of radiation field. So radiomic signature in peritumoral edema predicts subsequent recurrence. There are a few more papers coming on this field. So I will finish my talk with giving some what can happen in near future. We hope to have a diffusion, perfusion, DTI, and other advanced imaging in every scan in patients with brain tumors. Hopefully that our PACS will have software which can identify, segment, and extract feature from the region of interest. And then they can compare to the, like, we have a voxel to voxel comparison from the previous scan. So this is our hope, and we strive for that in the near future. Hopefully, we will have integration of all these softwares which can predict recurrence, and these cases can be very helpful in the near future. I will finish my talk here, and will be happy to take more questions.
I have to thank all the speakers for their very erudite presentations, Dr. Olson, Dr. Defoe, and Dr. Mangla. Now the session is open for questions if everyone is available. Right, so any questions from the audience? Yes, can we hand over a mic to?
Tracheotomy for low-grade gliomas. How do you deal with the SMA syndrome that you have during awakens, the section, and the role of intraoperative neuromonitoring versus awake craniotomy?
Hello, can you hear me?
Yes, we can. Yes, we can.
Please, can you repeat the question because I did not hear the question. Sorry about that. No, but the chairman, because I cannot hear if it's in the floor.
So my question is, how do you deal with the SMA syndrome, the supplemental motor cortex, and the transient weakness or speech loss that happens during the awake resection of the low-grade glioma, and your thoughts about awake resection versus intraoperative neuromonitoring?
In fact, what I do is to avoid to go directly to the supplementary motor area. If you have a premolar and frontomesoral lesion, then you will remove the anterior part, the lateral part, and the deep part. And finally, you will go to the SMA and its connectivity. Remember that the most important is not the SMA per se, but also the frontostriatal tract and the frontal astron tract in the depth. And then I will remove it at the level of the end of surgery, namely approximately the 10 last minutes. And you know that you have 10 minutes in front of you in order to be directly into the contact of this connectivity. So that means that if you start, of course, by the SMA, you will induce a transitory deficit, but you will not allow the patient to continue to help you for the rest of the surgery. So adapt your surgical strategy according to this knowledge of the transitory deficit you will induce.
Thank you. I hope the answer is adequate for you, Dr. Hashmi.
How do you find the role of functional MRI for awake craniotomy or functional MRI versus brain mapping?
If I am well understood, because once again, it's very complex to understand, it's a functional MRI versus intraoperative mapping. That's right?
Yes, that's right.
Okay. The fMRI is not able to tell you if an activation is critical for the function or not. I spent my life, 25 years, to remove activations related to preoperative fMRI performed elsewhere, and the patient was not selected for surgery because of that. And finally, what I did is to remove the tumor and the activations. And of course, the patient could have, once again, transitory deficit after surgery, but will recover thanks to postoperative cognitive rehabilitation. So that means that fMRI is dangerous because will push you not to select patients which in fine could be operated on. So never use fMRI in order to do a pre-planning. I use fMRI. I am PhD in fMRI. I know very well. I use fMRI for research, explaining why so many papers, to better understand the mechanisms underpinning plasticity by doing preoperative fMRI and postoperative fMRI during and after the transitory deficit induced by surgery, but never to do intraoperative pre-planning or mapping. Of course, I will ask systematically to all patients to be awake, explaining why now we have more than 20 years of median survival in the literature. We published that just this month, explaining why it was not in the diaporamas you have seen. And with preservation of the quality of life for at least 15 years in patients able to work in more than 94% of cases. This is unique in the literature. And you know why? Because I do not use functional neuroimaging into the OR.
Thank you, Dr. For another question from Dr. Ahmed.
In one of your papers, you described a case of a large low-grade glioma, which you initially treated with temozolomide. And when the size of the tumor decreased, then you just operated on the reduced tumor size. So can you please explain this one, or are you following the same pattern in more patients?
Yes, in fact, we will use this strategy to do neoadjuvant chemotherapy before first or second or third or fourth surgery if there was an invasion within the connectivity. Definitely for neurosurgeons and for radiotherapists, we have to understand that these white matter tracts are the limitation of neuroplasticity. So if, unfortunately, the tumor is migrating too much within this deep connectivity, you know that will not achieve so good resection. So you will not have an impact on the natural history of the disease. So it's better in these cases to use adjuvant chemotherapy and definitely not radiotherapy, which is a limitation of neuroplasticity, but chemotherapy first. I do not speak about vorasidenib because this is too early. We need more follow-up in order to conclude, at least to my opinion, 3 to 5 more years of follow-up. Then by doing chemotherapy, you have approximately 50% of chances to see a shrinkage. And of course, it will not be within the core of the tumor, but at the level of this migration of the connectivity. And then you have a chance to reopen the door to a new surgery or first surgery, and then to decrease significantly the volume of the tumor, so to decrease the risk of malignant transformation in low-grade glioma, and of course, by preserving the quality of life, because the patient will have post-operative cognitive rehabilitation and should return to a normal life, including to work, once again, in more than 95% cases after 3 months. So it's really a new strategies which should be more discussed in tumor board everywhere in the world. And of course, it's not done because the classical protocol, you know that my protocol is that I have no protocols. This is the reason why all my patients are living longer and better.
Yes, Dr. Ahmed, yes.
One more related question. That the tumors that respond to chemotherapy can also respond to radiation. So if in the similar patient, can we do a gamma knife, which is focused radiotherapy, to the area of T2 intensity? And it will also, what we have seen in our cases, that it decreases in size, as we have seen in this case of temozolomide. And then to operate on a reduced size tumor according to your recommendation.
Problem with the gamma knife is that it's not adapted to this kind of diffuse tumor. I would like, of course, to have a more better radiotherapy, but it's not possible. I mean, when you have to irradiate, because this is a diffuse glioma, and finally, you have to take a margin around what we can see on the pre-radiotherapy flare. Otherwise, you will leave more tumor on cells. And this is the reason why my goal since 25 years was to postpone radiotherapy. So that means that if temozolomide does not work, you will be finally obliged to irradiate, but as late as possible. Otherwise, you will see a decline of the cognitive functions of the patient. So radiosurgery, to answer more precisely your question, we used it only if you started to see one focus of likely malignant transformation in the middle of the tumor, not accessible in the depth, through or enhancement, which did not exist in the previous MRI. I speak about a very small focus, or through the PET scan, because more and more we have the habit to try to anticipate a possible malignant transformation before the occurrence of enhancement on the classical MRI by doing regular PET scan with L-DOPA. And if you see an hypermetabolism, then we can be tempted, yes, in this specific case, to use radiosurgery at the level of this focus by giving also chemotherapy, for instance.
Thank you, Dr. Defoe. Of course, if I may add, Dr. Olson did mention that she is giving preoperative radiation, focused radiation, radiosurgery to lesions, but then these lesions are the more demarcated lesions, such as metastases, or which are, of course, well demarcated. Dr. Olson, would you have a comment on that, please?
Yeah, no, I was fascinated by that, and totally respect what Prof. Defoe was saying, delaying radiation in our current form as long as possible, because those patients really, they don't do well. I think one of the interesting things coming out is Professor Dan Trivoletti from Mayo Clinic. He's actually doing, this is on not low-grade gliomas, on high-grade gliomas. He is doing preoperative radiation in a more gamma knife or 3 to 5 fractions cents before surgery, and then they are completing adjuvant chemo and radiation as normal afterwards. But I think that will be a very interesting space to watch, the preoperative irradiation of glioma in a more defined space, as you were saying, rather than the more diffuse radiation we usually see post-op. We also sometimes use gamma knife when patients have escaped all other treatments and they have a focused area that is troublesome, but it's really salvage. Thank you.
Thank you, Dr.
To be
Olson.
honest, I do not understand why to do a preoperative radiotherapy, because my goal, even in glioblastoma, I did not speak about that today, is not to remove the enhancement, but to do lobectomy according to the functional boundaries. I mean to remove the flare as much as I can. So how do you want to irradiate before surgery what I will remove during surgery? So we have to adapt to what I left according to the intraoperative mapping. Never I will just remove enhancement. Never. Otherwise, I will change nothing in glioblastoma. My glioblastoma patients are living 3 years.
Yes, thank you. Thank you, Dr. Fo. I think your point is well made. Any questions for Dr. Mangla? Yeah.
Assalamualaikum and hello, I'm Intizar Fatima, currently 4th year medical student from University of Lahore. So my question is, can artificial intelligence driven multi-parametric imaging improve the diagnostic accuracy in detecting cancer of brain tumors as compared to the traditional imaging modalities? Thank you.
I think Dr. Mangla is not with us. He's not connected virtually, so we can post. We can post him via an email.
Yes, of course. But I think that considering the gist of his talk, we can answer that. Certainly, I think that artificial intelligence would be able to get together more of the parameters together, voxel to voxel, and make a voxel to voxel comparison. This is the point that he was trying to make in his talk. So that would increase the diagnostic accuracy. It's very interesting that as human beings, we tend to imbibe a lot of these things over the years, and then with a glance possibly, which may of course be wrong, we tend to come across and say, yes, this appears, this is a glioma, or a low-grade glioma, or glioblastoma, or a radiation necrosis. But of course, there are, in these complex cases where you have a glioma which has had radiation, which has had chemotherapy, possibly multiple surgeries. So you have areas of within the tumor which may go either way, radiation necrosis or recurrence or elsewhere. Many times you actually have to wait. But then again, something that can compute very quickly and give an answer will certainly help. Now, just a little comment. Sir? Yes.
Yes, sir, Asad here. Thanks for putting my pictures in your presentation. So just one short question. That after how long after SRS would you wait to label the tumor is not responding to SRS? Like I'm talking about skull basement angiomas primarily.
Yes. Well, that's a difficult question. Yeah, and well, certainly as we've talked about, a 3-month scan, first 3 months, anything can really happen. And after that, I think we start getting a bit more concerned. But we know if you're talking about radiation for skull-based meningiomas, I think, as we were saying, is that, they really do very well with radiation. The thing that is causing me a bit of cognitive dissonance at the moment is some of those larger ones in the older patients I think I was alluding to. I always thought they would always go to surgery, but now we have another potential option. I think to answer to your question, the first 3 months, anything can really happen. We don't expect, we're lucky if a quarter of them reduce in size. But, after that first 3 months, I'd start to becoming a bit anxious, I think.
I think my question was rather similar as well. We have a lot of patients who have been given radiosurgery, and that is for yes, skull base. If you include the acoustic schwannomas as skull base tumors, but we have these patients with lesions sitting right next to the brainstem who come back to us month after month with rather nebulous symptoms of imbalance occasionally and headaches and possibly facial numbness of a transient nature, and then we have to jolly them along until things start to settle. I tend to wait a little, become anxious, of course, at 3 or 6 months, but then jolly them along, and generally they do tend to settle, and we don't need to go ahead with performing surgeries for these relatively smaller lesions, at least. So yes, that is always a major cause for concern. Thank you very much. I think if there are no further questions, another question? Yes, coming through.
Dr. Olson, what's your experience with atypical meningiomas regarding radiosurgery with these two?
Yeah. I've just got a lady on Friday with it. She's got an orbital one, and I think I had it in the presentation. I think that's a domain of neurosurgeons, and she had radiation as a kid for leukemia. So that's where we seem to be seeing the atypical ones. And it's funny that radiation causes the meningiomas, and yet we're going to also treat them with radiation. So we often we don't give radiation necessarily up front if we've had a good resection. We might use the dotatate PET scan to see if there's any tumor still around that we just can't see, or might be contributing, saying that it's scar tissue post-surgery. I think the dotatate PET scan's been quite a game changer for me, particularly in reassuring patients they don't need to have surgery, but also in helping us decide when we need to give post-operative radiation. We don't necessarily give it if it's atypical, but if the dotatate PET scan's showing that there's still quite a bit there, particularly if it's got sort of that more sort of a leptomeningeal kind of look, we might increase the prevalence of the scans, but also think about instituting radiation earlier.
Thank you, Dr. Olson. Any further questions before I round off? It's very interesting. I've been practicing neurosurgery now for the last about 35 years, I should suppose. Things have changed a great deal. Initially, I will go back to a joke that's rather apocryphal, but possibly correct, knowing his acerbic nature, and that's about Fred Epstein. A medical student once asked him what he was cutting into. He said, "Young man, if I knew what I was cutting into, I wouldn't be cutting into it." So things have moved on a great deal from there, as Dr. Defoe's talk has shown. And of course, as Dr. Olson says, we have to treat the patient individually, not the tumor itself, but each individual patient according to their needs and according to their aspirations. So I think that from that, we will sign off here today. Many thanks to Dr. Olson, Dr. Defoe, and of course, Dr. Mangla, and all the audience here today. I hope that this has been informative and will possibly help us change our practices in the future. Thank you.
Thank you very much.
Thank you.